it's not infrequent that you see patients who have had a poor TUR or incomplete TUR, which either does not define the disease actual stage, or it is too much of the tissue left behind and you need to really do another procedure. We know that TUR is a cornerstone of management of both non-muscle invasive, muscle invasive bladder cancer. An incomplete TUR essentially means that you can have an early recurrence and you may miss out a muscle invasive cancer. And this is the EUA recommendation that you're all very aware of. So one of the problems is the PTX. So a lot of TUR BT reports that patients who have had the procedure outside, they come to us, they have a PTX report, which means that the muscle was not there, and as such, you have to do another TUR. This is a small study conducted from our center, one of my residents, presented in the World Congress of Endourology last year, and doing a R-block TUR BT and comparing it with the piecemeal resection. There are two very simple, straightforward findings. Number one, that the patients who have had a R-block resection had 100% muscle in the primary.
Sorry, actually meeting
whereas only about 56% had muscle in the primary tumor. The other thing is the quality of tissue for histopathological evaluation. You can see the tumor itself, the muscles, whereas there are a lot of burning, the cautery artifacts in the piecemeal resection. Actually, while we're doing it, you can show to the residents and trainees the muscle which is visible when you're doing an R-block TUR. Third problem that we face is that urological community in Pakistan put a lot of trust on the intravesical treatment. They do a half-hearted TUR and they think the rest can be done by the intravesical treatment. We know from literature that residual tumor is one of the major factors in the failure of intravesical treatment. So you put BCG or mitomycin, depending upon whatever the stage and grade of the tumor is, you may find that your patient's not going to respond because there is a residual disease. Sharing one case just to illustrate my point, a 48-year-old landlord from one of the biggest provinces in Pakistan, and unfortunately the most underdeveloped. He is known to have pulmonary tuberculosis, hypertension. He had a TUR BT, which the report says that high-grade cancer with no muscle. And he was started on BCG and he received 6 cycles of BCG, developed hematuria and sought to consult us. And this is the CT at the time of his presentation to us. You can see that there is an extravesical disease here on the left lateral wall, and there is dilatation of the distal ureters, clearly indicating that we are dealing with not a non-muscle invasive, but a muscle invasive cancer. He refused neoadjuvant treatment. We did per-operative paracollicular biopsy, which comes out to be positive, unfortunately, for a young man like him. And we have to do an ileal conduit with a cystectomy and lymph node dissection. The fourth challenge is the incomplete histopathology reporting. And we know from literature, and there are very clear guidelines, that lymphovascular invasion and presence of an aberrant pathology, histology, is a very significant impact on the overall survival of these patients, along with obviously the stage and grade and presence or absence of muscle. And this is what is being recommended. Our own data shows, this is something that one of my residents who is currently working with Mr. Chaplin, Mavish, wrote this paper a few years back. The overall incidence of variant pathology along with the urothelial cancer was 11%. And this variant pathology cancers have significant impact on overall survival and the morbidity of management. So the fifth challenge. Now the fifth challenge is that this is a patient who clearly needs a cystectomy, and I'm the one who doesn't do cystectomy. So my response is that I can't do it, homie, it cannot be done. Not that I'm going to pass it on to a center where it is being done. The other problem obviously is patient's refusal, which is diversion issues. People would like to avoid contact of urine to the skin because of religious reasons. Sometimes I've also seen that patients who have been referred for neoadjuvant chemotherapy and they develop a clinical T0 disease, or even on cystoscopy if they do not have disease, they're very reluctant to go for cystectomies and rather had completion CCRT or radiation therapy. And I really consider that a bladder sparing protocol is for a very select group of patients, and it's not for as an option if you have had your chemotherapy and you want to continue with that. So EBRT trash can, that's what I call it, is dumping patient to this radiation therapy group. This is data, single center data from one of the leading institutions in Karachi. And again, you see that the overall outcome of CCRT is quite inferior, with short follow-up and about 50% disease-free. Obviously, we know that from large series and this over 8,500 patients from International Consortium on Bladder Cancer reported in Journal of Clinical Oncology some time back, that if you have an organ-confined disease, even 20-year survival is a possibility. It's nodal disease which really brings the survival down. This is our own data reported a few years back. You can see that the 10-year survival is over 45% for patients who have had a cystectomy for muscle invasive or high-grade TCC. Radiation cystitis is a real problem with various pelvic malignancies, and obviously for patients who have had the radiation for bladder cancer. So I know I'm short on time, so I'm skipping this case, and this is a case which got delayed because of COVID. He had twice COVID positive, and this delay resulted in a significant advancement of his disease. He had a squamoid differentiation, and this is the protocol that we were following at the time of the peak incidence of COVID in Pakistan, which was April to July. He ultimately underwent a cystectomy, and it showed a high-grade urothelial cancer with squamoid differentiation. The patient unfortunately developed very early on recurrence of disease, and as you can see that within 6 to 8 weeks, he developed a large recurrence, although he had only one positive margin on his radical cystectomy, and none of his 21 lymph nodes were positive. So this is a real problem that can occur with delay. Morbidity of the procedure is a real issue, and this is one of the reasons why a lot of young people graduating even from centers where they have seen and assisted in radical cystectomy are reluctant in taking one. Over the years, we have tried to decrease the morbidity of procedure by changes that are known worldwide in terms of the ERAS protocol, the dissection as much as possible is staying retroperitoneal, and then about 80% of the cystectomy and all lymph node dissection is done as a retroperitoneal procedure, and then ultimately you can go transperitoneal and complete your cystectomy. And all this with early mobilization and avoidance of epidural anesthesia have really improved or decreased the incidence of gastrointestinal complications. So I would like to conclude, and I apologize, I think 3 minutes over. If I can just, Zishan, with your permission, would like to share my own personal journey in just one slide, and I'll take not more than 1 minute. So my first exposure to radical cystectomy was when I was working at Central Middlesex Hospital in London many decades back. And Malachy Gleason, who came from MD Anderson at that time, was the one who was doing Indiana pouch and radical cystectomy. And I have had the first hand, even at that time in 1995. Subsequently, I, with a colleague, Suleiman, started doing radical cystectomies in Karachi between 96 and 98. And then I have had the good fortune to go to Fritz Schroeder's unit in Erasmus University in Rotterdam, where I have had good exposure of radical prostatectomy, which really helped me in doing the prostatic dissection. And then the life-changing opportunity to get a scholarship to visit Professor Studer's unit. And this is something which really was the paradigm shift in my career as far as the radical cystectomy is concerned in orthotopic bladder, learning from the maestro himself. And subsequently, my last stop was at Leuven with Hein van Poppel, another master in open surgery of the pelvis, where I learned the apical dissection and nerve sparing. So thank you very much for your attention, and my apologies for going over time.
Thank you very much, Professor Thurworth, for a very interesting, very insightful talk. And thanks for the last slide. It's always very humbling to appreciate those who have trained you. Great. So we would, I'm sure this sets the tone for future talks, and we will discuss about all these things during future talks as well. So we'll just move on to our next lecture. And for that, we have with us today Dr. Sheila Badiker, who's a consultant anesthetist at Guy's and St. Thomas's. And Sheila is also lead for urological anesthetics. And for radical cystectomy, as during my training years, I've always felt this is physiologically most demanding urological procedure. So Dr. Badiker will speak about anesthetic evaluation for this major operation. Dr. Badiker, to you, please. Do you need to unmute yourself? Yeah, I think, Sheila, you need to unmute yourself. Yeah.
Yeah.
Great.
Is that better? Yeah.
That's fine. You can start now, please. Thank you.
Okay, great. So thanks very much for inviting me today. It's a real pleasure to be able to come and give an anaesthetic perspective to this meeting. So thank you very much. And as Zishan says, so I work in London with the bladder cancer team at Guy's Hospital in London. So I thought the title of the talk today is How We Evaluate Patients for Cystectomy. So really, when we're asking that question, so when we see them preoperatively, when the patient is referred, we need to make a decision as to whether that patient is fit for surgery or fit for anaesthesia. And that is a big question. But what we also want to do at that stage is take the opportunity to identify those patients who we think will benefit from a preoperative intervention. So simply, that could just be pre-optimization of all their medical comorbidities, so their cardiopulmonary disease, their renal disease, diabetes, and so on. But it's also a chance to engage them in some sort of prehabilitation. So prehabilitation is something that in the United Kingdom is gaining a lot of interest. So that might be, so it's any measures that can improve the fitness of the patient. So it could be an exercise program, it could be a nutritional program, it could be providing psychological support in the run up to surgery. But also for us as anaesthetists, it's good for us to identify those who need some sort of targeted therapy. So targeted fluid therapy, intraoperatively, or those who will need some sort of post-op respiratory support and critical care input. So to do all these, to answer these questions, we see them in clinic. But what we know now is our clinical judgment, our end of the bed assessment is actually not a very good predictor of adverse outcomes. There was a large study in 2018, the MET study, which was published in the Lancet, and it was a large international multi-center prospective cohort study, and it was comparing lots of different risk prediction models, and our own clinical subjective judgment was a very poor predictor of adverse outcomes, which was actually quite a surprising result. So again, coming back to that question, how are they fit for an anaesthetic? Are they fit for surgery? So that's often something we get asked in theatre when our surgeons are doing a TURBT or doing a cystoscopy and biopsy, and it looks likely that they'll need a radical cystectomy. they often ask us, so how do you think they'll do? Are they suitable for a cystectomy? And for us, perioperatively, what we're really asking is, what are the chances of us having one of these measured outcomes? So the perioperative outcomes, they differ a little bit from the oncological outcomes, but 30-day mortality and incidence of a complication or adverse event. So this question actually has to take in quite a lot of factors. So patient factors, their frailty, their age, their comorbidity, how much they can do, but also their socioeconomic background and their geno or phenotype. But also what sort of care can we provide to achieve these outcomes? So the quality of care we can give, the critical care provision, and our ability to deal with any complications that arise. And of course, you know as well as we do that there is still, unfortunately, a degree of unpredictable and random variability. So I thought it would just be a good opportunity now to remind ourselves of some of the physiological effects of having an anaesthetic and having major surgery such as a cystectomy. So in the top picture here, you can see some of the effects of the anaesthesia drugs have on the body. So they all will cause myocardial depression to some extent. So the patient will drop their cardiac output and their blood pressure, either through contractility or a change in heart rate. They all affect the lungs. The drugs cause hypoventilation, reduction in ventilatory drive, and we're subjecting these patients to around 6 hours of mechanical ventilation and all the consequences of that. All the general anaesthetic drugs cause post-op cognitive dysfunction, although the exact mechanism of that is unknown. And there's other systemic effects that we are well familiar with, such as regurgitation, risk of aspiration, hypothermia, heat loss, and nausea and vomiting post-operatively. So that's just the anaesthetic drugs. And then there's also, at the same time, the body's response to having this major trauma of surgery. So the activation of all your neurohumoral factors, the body goes into a catabolic state. So sympathetic nervous system, your renin, angiotensin, aldosterone, your systemic catecholamines, everything causing hyperglycemia and coagulopathy. So it really is a big physiological assault on the body. We're often asked sometimes whether or not there will be a difference physiologically to a patient having an open procedure or a laparoscopic or a robotic assisted operation. Well, we're all familiar with what an open operation can do to the physiology. You have a big abdominal incision, there's a lot more, there's the blood loss, the wound infection, the ileus, the post-operative respiratory consequences of having the pain in the abdomen, the heat loss and the fluid loss. But actually for us, from our point of view, laparoscopic surgery isn't much less physiologically stimulating. So you have the pneumoperitoneum and the CO2 inflation all causing compression of the venous return. So again, further drop in cardiac output and blood pressure. You get a decreased you decrease in your functional residual capacity of your lungs because of the increased intrathoracic pressure, all leading to lower compliance and more VQ mismatching, so more of an oxygen shunt, so there's less oxygen around for metabolism. Again, neurological consequences such as effects on intracranial pressure and also a negative effect on renal and mesenteric perfusion. So then you have the effects of the anaesthetic and the effects of having the surgical trauma, and then for robotic assisted procedures you actually then also go and invert the patient because of this abnormal positioning, and that exacerbates all the cardiorespiratory and neurological problems that we've just been talking about. So it really is a big physiological event for that patient. So when we see them in clinic, it's really important that we have a robust way of evaluating their risk. Accurate risk prediction for us is a really important aspect of our perioperative evaluation and how we plan for their post-operative course and care. So we've already mentioned that subjective assessment isn't very good, and even though we rate it ourselves, our clinical experience and our own intuition actually isn't translating into predicting an adverse outcome. There's a lot of interest now in patient sero biomarkers, so in particular something called NT-proBNP. So that's a peptide released from the ventricular myocytes, and it has been found to be a predictor of having a perioperative cardiac event in a patient undergoing non-cardiac surgery. So some centres are routinely measuring the NT-proBNP. Then obviously we can do risk scores, which are very easy to do in clinic. So something like the ASA, but we also have complication-specific risk scoring systems. And then we can create a more complex model, so we can input data into a POSM or a SORT score to also give us a prediction of mortality. And then also what we like to do is to see actually how much can the patient do on a day-to-day basis coming up to their surgery. So we can do this with a physical activity questionnaire, or we can physically exercise the patient, for example, in CPEX testing. So we're hopefully all familiar with ASA. I think it's very widely used risk score. It's very simple. There are only 6 categories, and it uses the comorbidities of the patient to risk stratify someone. However, it is quite simplistic, and it also lends itself to a lot of observer intervariability, and it isn't patient individualized. It isn't specific for that particular patient. There are also some complication-specific risk scoring systems, such as the Lee Cardiac Risk Index. So this is for predicting the risk of a post-operative cardiac event based on the pre-existence of a cardiac or cerebrovascular disease. So a patient will get a number of points, and that will translate into a 30-day risk of a cardiac event. There's also something called the ARIS-CAT, which is similar for pulmonary disease. It uses respiratory parameters and operative characteristics and categorizes a patient into a low, intermediate or high risk, which you can then use to direct your critical care bed usage. And then we can put patient data into a more complex model. So this is the POSM. So again, you probably are familiar with this. So this has been around since the early 1990s, and it uses 18 variables, some physiological variables and some operative variables. And it takes these components and you can calculate a 30-day risk of mortality. Something that we're using in our centre is the SORT. So it's a similar model which uses less variables, but it can be used as at the bedside, and there's actually an app available so you can do it on your phone. It uses, it's validated based on data from observational data from the last NCPOD report, and again we get percentage risk of 30-day mortality, which we can use to make our decisions. So risk predictions are very useful, but unfortunately, as we know, none are perfect. We found that just by predicting the risk in the perioperative period actually does help direct clinicians to booking critical care bed as it compared to if we didn't do any. But actually what is also quite useful is to know actually the functional capability of a patient. So we also want to assess physical fitness. So we can do this in clinic with some simple screening. So METS is very commonly used. That's a metabolic equivalent of a daily activity. So a MET score less than 4, for example, would correlate with a poorer outcome. And we know that every MET a patient can achieve actually leads to a 15% reduction in mortality. But we can also use it into a more extensive questionnaire such as this. So this is the DASI questionnaire. So this is a self-reported questionnaire with 12 variables, and it is actually a validated measure of cardiopulmonary fitness. However, we're slightly uncertain of what exact threshold then correlates to elevated risk, but obviously the higher the score you're able to do, the better the perioperative outcome. And then we could take the opportunity that we're seeing them preoperatively to assess their fitness by making the patient exercise. So in clinic, we can do simple field tests such as the timed up and go walk, a 6-minute walk, or the incremental shuttle walk. And then we can use more elaborate testing methods such as the cardiopulmonary exercise testing. So this is used in several centres in the United Kingdom at the moment. So we take a patient coming for a major surgery, such as a cystectomy, and we'll exercise them either on an exercise bike or a treadmill, and we'll gradually increase the work of exercise whilst continually measuring their respiratory gases using this tight-fitting mask. And what we can do is calculate 3 variables, which give us an idea of how fit that patient is. So we can measure the VO2 peak, or the maximum oxygen uptake, and that's measured at the point that the patient gets their maximum capability or exhaustion. And that seemed to be the gold standard for measuring fitness, and it's often used by athletes as well that are in training. The other value you'll hear about is the anaerobic threshold. So that's the VO2 value at the point in which the body is moving from aerobic to anaerobic metabolism. And then the third is the ventilatory equivalent of CO2. So that's the volume of breathing you have to do to get rid of CO2. So the lower the value, the better, because that's the lower the value, actually, it means that there's better VQ matching in the lung. So those three things help us get an idea of how fit a patient is. However, so it's not universally taken up, cardiopulmonary exercise testing, because the evidence is still debatable about whether cardiopulmonary exercise testing actually translates into an improved perioperative outcome. However, there is evidence to say that CPET does improve and guide our risk prediction, and that can help us guide critical care provision and also the decision about whether or not to go for major life-changing surgery. And as I mentioned, these prehabilitation programs are gaining popularity, so we could use something like this in the preoperative period to exercise the patient to improve their fitness. So how do we put all this together in practice? So we've talked about how we assess their comorbidities and how we get an evidence-based number for their perioperative risk. And we've talked about assessing fitness of a patient. But as you know, there are several other factors that have an important role, such as how frail they are. They're all an elderly population now with more complex comorbidities. Have they got a degree of pre-existing cognitive impairment? So we do a cognitive test in clinic. Do they have any psychological barriers to achieving the recovery that they and we are after? So we do an anxiety and depression scale. And we also take that opportunity to assess their nutrition. We use something called the MUST scale. They're all cancer patients, so they'll all be calorifically deplete and maybe anemic. So we'll use that period preoperatively to assess their nutritional status as well. And this is an example of a table that we use in clinic to put everything that we've been talking about together. So then what do we do, and what approach do we take to translate all this to the patient and to make our decision? Well, in the United Kingdom at the moment, we're moving away from that traditional model where the clinician knows best and the clinician is directing the decision-making of the patient. So moving to something called shared decision-making, which is a much more collaborative approach from the surgeons and the rest of the multidisciplinary team, including us and all the allied health professionals. So we're taking our knowledge of not only their diagnosis, but also the etiology of the disease and their comorbidities, what their options are, and our evidence-based to predict their outcome, but also very much taking into account what the social circumstances and the social network of the patient is, what their experience is to date, what their attitude is to risk, and what their values are. And what we have seen is that they're using this approach, there are less likely to have patients that maybe go for the full surgical option, but it also means that the patients are finding that we're finding they're much more accepting of a poorer outcome or a complication because they've really been informed from the beginning and really part of the decision-making process. So this is the sort of the model in summary. So we're taking into account their preferences and their actions, our research evidence and our expertise to make those decisions. So this is an example of how we would document that sort of discussion. So at Guy's, we're very fortunate to have an excellent geriatrician-led service. It's called PAUS, which is perioperative care of the older patient coming for surgery. So we have a joint clinic with them for anaesthesia and POPs, and we'll go, and this is after they've seen the surgeon. So we'll document and discuss with them that we've had a discussion about the benefits of the procedure, so to remove bladder cancer, etc. So this is a real discussion, what the risks have been. So not just the surgical risks, but what could happen to their comorbidities and what could happen to their functional status, what the alternatives to surgery are that have been discussed with yourselves in clinic, and what will happen if we do nothing. So the patient gets a copy of this and it can help inform their decision-making in the run-up to surgery. So then how do we fit in with the overall patient experience and the whole pathway? So this is our flowchart for our enhanced recovery pathway at Guy's. So they come in the patients come in by their GP referral, they see the surgeons and they get the surgical investigations and the surgical consent process. And then they're seen in an enhanced recovery clinic where they see a specialist nurse, a dietitian, a stoma nurse, a physio, a psychologist to start doing the assessment and the preparation that we've been talking about. And then they'll either see ourselves or the geriatricians in the POPs clinic, and then we can bring it all together, assess their comorbidities, and then start the shared decision-making process. So that's been a very quick summary of the anaesthetic side of things in that preoperative phase for a patient coming for cystectomies. But hopefully we've just had a reminder of what a physiological stress a cystectomy can be and having a general anaesthetic for that length of time. And we've also touched on how and why we need to quantify risk and assess the fitness of a patient and how this informs our decision making and our perioperative planning. Thanks very much.
Thank you so much, Sheila, for a brilliant talk, and you have summed up in 15 minutes only. And I think we may have to skip the discussion section just to catch up with time on this. Mr. Chaplin, you have any comments to make?
Just two very quick ones. Two excellent presentations, really excellent. Very good perioperative figures from Professor Arter. I wouldn't get hung up about the blood loss. I don't think in the real world that anybody in the UK has 0% transfusion in real life urology. That's not the case. There's certainly less with robotic surgery, but not with open radical cystectomy. I too have worked with Professor Frischrode and worked in Rotterdam. And so yes, an extremely good talk. And Sheila's talk gets really to the heart of the matter. It's the one biggest concern I have with every single cystectomy patient is the anaesthetic. Well, the question whether or not a patient is actually fit enough for that operation and whether that is the right thing to do for a given patient. There's so many good things in that talk, but in the interest of brevity, I will keep it short. But a really excellent talk. Thank you.
Great, thank you very much. And congratulations, Sheila. Over 100 surgeons were quietly listening to you who wouldn't do that otherwise in operating rooms. So we'll move on to the next block, which is on the treatment block of muscle-invasive disease. And we are extremely grateful to have with us Professor Syed Hussain, who will, the two talks are combined for him. First, to speak about neoadjuvant treatment before the radical treatment, and then he will continue that with the talk on radical treatment for muscle-invasive bladder cancer. Why would I choose a radiotherapy? Professor Hussain, please. You might have to unmute yourself, sir. So on the bottom left, you might be able to unmute yourself. And
sorry, got it. I need to share my screen. Are you going to allow me that?
I think you can just do that. At the bottom of the Zoom screen, you will see the share screen option. It's usually highlighted as green.
It's asking me Zoom to share.
Just share screen at the bottom of the Zoom screen.
What I might do is that, if that's okay, I might email you. Looks like it's not working in that sense from my Mac.
All right. Okay, fine. I mean, is your window open for the Zoom? Otherwise, we can.
Window is open. Yeah, window is open. It is open on my desktop.
Okay, fine. It's just a share screen option at the bottom, green highlight.
I'm trying that, but it's just not.
Okay, let me just see if I can do it on my end. Otherwise, we'll move on to the next talk.
Zishan, what's your email?
I'll just text you my email.
Well, I got it. I've just sent it to you.
Okay, that's great.
It did work in my last meeting yesterday I had with my UAE Best of ASCO meeting, but for some reasons.
Can anyone else check they're not sharing a screen, because that could cause problem?
It's just not letting me share my screen. I have the green button, but either somebody is already open there sharing the screen.
If somebody else is sharing the screen, may I please request not to share the screen, please? No, I don't think anybody else is sharing the screen. Yeah, no, I don't think anybody else, because I am able to share mine. Right, so we'll just move on to our next speaker, if that is okay. Professor Stanzel, so are you ready for are you in a position for your lecture, or we have slightly changed things? Professor Stanzel is with us. So we'll just move on, and for our next lecture, slight change in the program, we are extremely honored today to have with us Professor Arnav Stanzel, Chair Urology, University of Tübingen, and he's also serving in EAU Secretary General Adjunct in the EAU Executive Office. And we are even more grateful because Professor Stanzel has been busy traveling, but he has given up his time for the webinar. So he would lecture us about muscle-invasive bladder cancer, why surgery. Professor Stanzel, please.
Okay, now Dr. Aslam and all the others, thank you very much for this invitation. I will be honored to give this presentation. Can you hear me okay?
Yes, we can hear you. Thank you very much.
Okay. I am at the German Urological Association. We are having a hybrid meeting here, but I have to congratulate you on this excellent meeting here, which I've been able to follow partially at least. It's an honor to be here, and I hope I'll be able to get to transmit this presentation. Now, these are my, these are my conflicts of interest. You know, when we talk about cystectomy, why cystectomy, we always have to think about the survivorship, the long-term follow-up of the cystectomy and the urinary diversion. So it's always, you know, it's a balancing between oncology and function. You know, this picture, this is a gentleman that from the former World Towers in New York was balancing over. Anyhow, but that's not what we want to talk about. When we talk about cystectomy, we know that not every patient will be able to have a cystectomy, but those that we have an indication for, those are the ones that definitely will benefit. And it depends on the tumor, it depends on the age, it depends on the comorbidities, the surgeon, the hospital, the gender, and the techniques. Part of it has been very nicely discussed in the first block here, especially about frailty and which surgeon and hospital. We'll get to that, but I'll just jump over that because you heard a very nice presentation. Now, at this year's virtual meeting of the EAU, there was a nice presentation on the Stockholm project, bladder cancer project. And what they were looking at is not only what is the incidence in Sweden or Scandinavia, but with the excellent registry, they were looking at the long-term mortality and the long-term mortality due to different stages and grades of the tumor. And we know a lot about, of course, bladder cancer and long-term outcome, but here they were nicely able to show that there is, of course, a high long-term bladder cancer specific mortality. More than two-thirds will die from the disease over a period of 15 or 10 to 20 and plus years. But also, you know, the non-muscle invasive disease can be lethal in up to a quarter of the patients. They will not die because of age, but they will die because of the bladder cancer. And by having a good treatment for bladder cancer, we will be able to give them a longer life. And especially we should look at these patients more than 5 years, especially in the G2 tumors, and especially those with T2, T3, T4, because their delayed recurrence will actually then be responsible for the mortality due to bladder cancer. If we look at the guidelines, I mean, those are not dumb people, neither in the EAU guidelines nor in other guidelines. And for muscle-invasive bladder cancer, radical cystectomy is still the curative treatment of choice. And there are a couple of things which we have to be aware of. You shouldn't delay the treatment for more than 3 months. You should perform a lymph node dissection and so on. So there are some criteria, especially lymph node dissection and the neoadjuvant or adjuvant or perioperative chemotherapy should be part of it, especially in the non-organ confined disease. In this long-term outcome meta-analysis, we see here that the 5-10 year recurrence-free survival is in the large series way beyond those 50% that are quoted at some other smaller series. So you have 2/3 that will survive 5 years or 10 years and longer, and that really is encouraging. But on the other hand, you know, there's still people dying, and it's a large amount of people. And then the question is, can we achieve the same thing with a trimodal therapy, avoiding cystectomies? That's what patients a lot of times ask. But if we look at, you know, at this meta-analysis, which we did, that if we compare the trimodal therapy with a radical cystectomy, then the neoadjuvant chemotherapy is significantly higher, in a higher amount seen in the trimodal therapy. So they get the neoadjuvant chemotherapy plus the radiochemotherapy of the trimodal therapy. So these patients undergo quite an extensive chemotherapy, and you cannot do that with every patient, and not every patient will be motivated to undergo a lot of chemotherapy just to preserve the bladder, and later on have the long-term morbidity due to the radiation which comes with it, and the long-term outcome, or not the long-term morbidity from the chemo. We know that cisplatin is the only one that is truly worth it to give to the patients, but these have also long-term morbidity to patients. And the nomograms for a trimodal therapy, as you see here at several there are several publications, but that is the one of the official ones. These nomograms, actually, what they show is that the best patients are those with an organ-confined disease and those with a macroscopically complete TURBT. Now, the question is, male patients with a thicker bladder, with an organ-confined disease, with a complete TURBT, those are sometimes the ones that actually do have without any further treatment, could have an overall survival. Very nice paper, just been published on EPUB by Richard Hautman. More than 35 years of experience from a single center, starting with the ileal neobladder. Because if you do a cystectomy, you want to have a survivorship with quality of life, then these patients need to be treated with a orthotopic bladder substitution, or with a bladder substitution that will more or less give them the same life in the continuing years after they have been cured from bladder cancer. And what he was able to show, it is a small percentage of patients, but it shows that these patients do have a continuous continence. It shows also, you know, these are male patients, only male patients, that in male patients, we also have residual urine, we also have intermittent catheterization. So it's not only, I'll come to that later in a minute, not only have clean intermittent catheterization, but it's also in the male patient. It's quite a percentage. But anyhow, these patients can be followed for a long time with very good functional results. And cytoreductive treatment, even in the metastatic disease, is also something that will give patients a longer life. So it's not only reducing the primary tumor in patients maybe with advanced disease, but also in metachronic metastatic disease, you take out some of the tumor, or at least a high percentage of the tumor, with subsequent systemic therapy. These patients will fare better than those without any reduction or metastasectomy. So surgery does have an impact. Surgery has an impact not only in the urothelial cancer, it definitely also has in those patients with urothelial carcinoma, mixed histology, up to 30%, 30, have that mixed histology. And these patients definitely will benefit from cystectomy, from removal of the bladder. In some of the cases, carcinosarcoma or nested variant and micropapillary tumors, even without neoadjuvant chemotherapy, right away, do surgery as much as you can to have these patients survive. Now, the other thing is, of course, not only generally burden of cancer is shifting to the elderly, but we also know that bladder cancer, of course, we have nice statistics, it's the disease of the elderly. And people tend to live longer now, but they live longer with reduced organ function. And the cisplatinum, again, the only really true systemic component of a multi-chemotherapy, that is the one that cannot be given in up to 50%, 50, beyond an age of 65 to 70 years. And these are the patients, then what do you do? Now, these elderly patients, they still have a long expectancy of life. And we have more tumors, and we have more tumors in an aging population that live longer, but cannot have a platinum-based chemotherapy. Let me give you an example. This 89-year-old lady, lovely lady, she came in with her younger sister, 86 years old. She had a bleeding, non-organ confined tumor, and she definitely could not have, due to her renal function, any systemic therapy. Radiation therapy, because of the bleeding, already dysuric bladder, was not an option either. So what should we do? Now, first of all, we have to think her life expectancy, and in the first block you have seen not only life expectancy is important, but also the frailty, whatever you take as a frailty. There was an excellent presentation by our anesthesiologic colleague now, just a couple of minutes ago. It doesn't depend on, but it's important because frailty will also give you a nice indication, not only what, if you should do a cystectomy, what type of urinary diversion. And you can really now evaluate, and you should do that. And I must say that in the UK, you're doing it a little bit better than in Germany right now, with regards to the geriatrists being on the tumor board, for example. And these are the ones that are really very, very important points. Now, of course, other anesthesiologic factors, you have seen that. These are important. Now, what do you do with this lady? What did we do? Now, we have to really have a fantasy a little bit. We looked at the nutritional status. We thought we should not do a general anesthesia. So we did a cystectomy and under spinal anesthesia. It is possible. You can talk to the patient while you do a cystectomy. Of course, you have to observe. You have to be really above the navel. You should not touch anything, because that is what spinal anesthesia will, that pain will not be taken away. And the type of urinary diversion, ureterocutaneostomy, seems to be old-fashioned, but for these ladies, can be great. They should stay in the IMC, in the immediate care center, short, because every change of surrounding in the hospital will eventually be a burden to the patient. So get her to the ward as soon as possible, and get her to the surroundings she has seen when she came to the hospital. And then, of course, she needs a geriatric rehabilitation, and she continues coming back for her semi-annual control. Of course, you ask her why, but you know, you want to have a urologic control, and she comes in with her younger sister, and it seems she does not is not more frail due to her operation than her younger sister, and she continues to come. Now, unchanged, no nicturia, no anemia, a normal social life. And you can do that, and ureterocutaneostomy is an option in these patients, the elderly patients. Now, what to do with the positive nodes? That is sometimes, you know, you shouldn't do any surgery, maybe no cystectomy if the patient has a positive node, but that's not true. And you can see that we do see with increasing T-stage positive nodes, but these positive nodes still have, over the decades, a good survival of these patients despite positive nodes. So positive nodes is not does not mean death to the patient, or you shouldn't do a cystectomy, but with a cystectomy with an extensive lymphadenectomy, or even better, a systemic therapy if possible, then these patients will have a long-term survival. Now, let me, another thing here, N1, 78 years old, you know, little, not in a perfect state, and a patient that eventually was shown to have a PT3A, not on a clinical 3A. This patient survived. He survived with an ileal conduit, and this patient did have a, this patient did not have any chemotherapy. He continued to be followed now for 4 years, and there is no recurrence. Of course, there are other cases, but I show you in the nice, good selection, these patients with good cystectomy will survive, and they will have a good survivorship, a good quality of life, because, you know, they don't have to get up at night, and they actually get very accustomed to their stoma, and they even have a higher quality of life than they had before, or if they would have had with their bladder insufficient voiding, all kinds of lower urinary tract symptoms, more or less. Which surgeon or hospital? I go over that. You have seen that. You've also seen the guidelines that actually say we should be looking at the number of cystectomy per year, should be maybe 10 or more per year. Then the morbidity and the mortality goes down. So really, that is something where the experience comes in, and that should be something which we should have in mind. I'll jump over that because you've seen that, and it's not only the surgeon alone. The surgeon is an important factor, of course, we all know that. But of course, the institution itself is also, you know, important. And it's not always universities, because sometimes, you know, teaching doesn't make the statistics better, you know. It's the hospital that does a high frequency and has some good surgeons with it. Nurse-bed ratio, number of operations, a teaching status, which is a little bit difficult, the comorbidity score, of course. Now, gender, is cystectomy something not for the female patients because they will end up with a ileal conduit? Well, that is not true, and I've been fighting for that, you know, like this 67-year-old lady, organ-confined disease, you know, why should she have an ileal conduit? She said, if I have a bag on my stomach, I will not undergo any surgery. You can forget about it. But, you know, we know that oncological outcome if we leave the urethra in and do an orthotopic urinary diversion, that these patients have over the entire spectrum the same 5, 10, and 15-year survival than the male patients. 66, 2/3 will survive 15 years with their urethra intact, with an orthotopic neobladder going with it. That was a multi-institutional study from 3 major institutions in Europe. And these patients do have a very good survivorship. It's, you know, it's the clean intermittent catheterization. They can be brought down in the female as well as in the male patients. Female patients, 11%. You have seen the male patients in a large long-term series, 15%, and they will have not be any better with the clean intermittent catheterization. You have to follow a couple of things, and continence, of course, is the other thing in the male and the female patients. If you do a cystectomy, if you want to give them a good quality of life, you do an orthotopic neobladder, then day-nighttime continence is important, and self-catheterization has to be as low as possible. Now, type of urinary diversion. Of course, the orthotopic neobladder is a preferred one if possible, but ureterocutaneostomy, as you have seen in the elderly patient, yes, that is an option. Ileal conduit is the most popular, no, I wouldn't say most popular for the patients, but most popular for the surgeons, and the most frequently used one, the elongation of the ureter to the skin with an ileum. But the ureteroileal rectosigmoidostomy, for the young patients that cannot have an orthotopic bladder substitution, is an option, because as soon as you put ileum in between the urothelium of the ureter nerves and the adenomucosa of the rectum, then these patients are safe from secondary adenocarcinomas of the bowel. And continent cutaneous, this was not on purpose, but continent cutaneous reservoirs, they're going down in numbers, they're less popular due to the morbidity, due to the possibilities of other forms of urinary diversion. This young gentleman photographer had something to do with chemical substances. He wants an orthotopic neobladder, of course, and he got it, and and I've done this 23 years ago. So now he is approaching 55 years old, and something wrong with my calculation, but he's about 50, and he is living an excellent life and within his orthotopic neobladder. And as you have seen in the Hautman just recent paper, these patients have a very long-term good functional outcome. And of course, he needs nerve preservation, which can be done nicely with a cystectomy. We have done studies with the periprostatic nerves, the nerves that are around the seminal vesicles, and we have just very recent data about the course of these autonomic nerves around the bladder specimen in the cystectomy. Will come out with that in very few. Now, which configuration of the bowel, which is important, because now with the laparoscopy and robotic cystectomy, we are getting all types of different reconfigurations, but we should not throw overboard what our previous colleagues have shown. We need the 4-segment, whether it be an M or W or the Studer or pouch. We should not throw over that wind chamber principle and not do a U or maybe S pouch just because Da Vinci, it's easier for the Da Vinci or Y Da Vinci reconfiguration. If we do an ileal conduit, then you can see here we do have a very considerable number of patients that will undergo a change from their conduit to an orthotopic neobladder or to other forms of urinary diversion. Now, last thing is technique. Which technique? I've just mentioned briefly Da Vinci and laparoscopic robot-assisted cystectomy versus open cystectomy. Now, which one is better? And we don't know yet. We have the RAZOR trial, we have the MSKCC trial, we have other trials just recently. You know, it's not out there. The important thing, and I have to quote Urs Studer at the EAU meeting a couple of years ago, it does not really matter whether you use a robot or an open surgery or laparoscopy. It's the surgeon behind. The surgeon should be experienced. He should get all kinds of urinary diversion, have these in his armamentarium, and then, you know, really juggle whether this is an old patient which needs maybe a ureterocutaneostomy, or is a younger, very motivated patient or a female patient that will need an orthotopic neobladder. That is the important thing. So in conclusion, just what I wanted the messages I want to get over is the tumor cystectomy can be curative, should be curative in most of the cases. It can be palliative if it's bleeding and no other options is really giving him a good quality of life. And the reconstructive part is important, especially in the younger patients, for their survivorship. Age, frailty, very nice presentation in the first block here. The comorbidities, they are adjusting the type of maybe anesthesia, maybe spinal anesthesia, or the type of reconstruction you do. Surgeon hospital, again in the first block, these patients need to go to surgeons and hospitals that have an experience, that give them the entire spectrum of urinary diversion and cystectomy possibilities. There should not be any difference in the gender, in the indication for the type of urinary diversion, especially the orthotopic neobladder. And the technique, for the moment being, we do not have strong arguments for one or the other. It's still the quality of the surgeon that is important. So if you have any more questions, please send me an email. I actually don't read it. My secretary reads it, so it takes a little bit longer of time, but I'll be happy to answer any question. I'll be around for a couple of minutes if you have any further questions. Thank you again for the invitation. End of presentation.
Thank you so much, Professor Stanzel. What an absolute pleasure listening to that. And I would just request our panelists and senior colleagues just to have anything to discuss with Professor Stanzel before he has to get back to his meeting in Germany.
Zishan, can I come in with a question? Just a quick.
Yes, please.
Yeah. Thank you very much, Professor. It's an excellent talk. I think 2 or 3 things you raised. First, the use of spinal anesthesia in patients who have lots of comorbidities and frailty. And second thing you mentioned about the interposition of ileum into the rectus sigmoid, particularly in Pakistan or areas where patients have an infinite disrelish to any cutaneous stoma. The question I have for you is, do you think in those situations, MINDS 2 would have an application, particularly because those patients, they are from remote areas. So that's one. And second, you mentioned briefly about the ileal conduit and various ways of reimplanting the ureters into it. And the question I have for you is, I mean, what are your views about the modified Mansoura technique, where they move the proximal end of the ileum across to the other side, so without compromising the blood supply of the ureter or any tension? Thank you.
Well, thank you very much. Three questions now. The one is the spinal anesthesia. You know, I'm not favoring that, but I'm just saying, you know, if you go to the old, the frail patients, general anesthesia may at sometimes, and I think our anesthesiologic colleague will tell you better, they may have some problems, especially if there's comorbidity like Parkinson's disease and others, with a general anesthesia. So there is a possibility, but really you have to be really good team with your anesthesiologist, and then you know, you have not to touch anything in the upper part of the abdomen, because that's going to give some pain. You need the patients usually have some sedation. You need to be quick. Yeah, of course, you know, it can be, it needs to be a quick surgery. Now, I'm not favoring it. I'm just saying there is a possibility with that. There is a possibility of also, you know, thinking about, even if you do general anesthesia, about, you know, nutritional status, the type of anesthesia you give to these patients. The second question was the ureteroileal cutaneostomy. Sorry, the ureteroileal rectosigmoidostomy. You know, it's something we should not forget, especially when you talk about patients that in a remote area have problems getting the external devices. They cannot have a bladder substitution, they cannot or do not want to have a continent pouch. And with that, I do 2 things. First of all, the patient gets an enema. So, you know, he gets to feel it. Yeah, because that is important. Otherwise, it's a social problem. And the other thing is, it's known, urothelium, the rectosigmoidal mucosa, stool, and urine. Those 4 factors are responsible for the secondary adenocarcinoma. So if you can exclude by putting ileum in between, yeah, then, and in addition with the ileum, you get an augmentation of the rectosigmoid at this point, then you can really do something. And I've done that in younger patients with bladder exstrophy, for example. You know, bladder exstrophy, these patients, you know, those are young patients, they did not want to have a stoma. There are several reasons for other reasons for that as well. And so it does work. I'm not saying you should do it, but you could do it without the long-term danger. And the third one was, whoops, I forgot. What was the third question? Sorry about that. There was something about, oh yeah. Yeah, of course. I do not see any problem of putting the left ureter underneath the mesentery root to the right side. In the majority of cases, I'll leave it, but I've had cases where you had to have the ureter short due to tumor, dysplasia, you know, we do a frozen section, maybe even before you looked it up and you said, well, the ureter looks, doesn't look very good. So then you can pull the ileum to the left side underneath. I've done that, figure of 7, you know, or how do you say it? The opposite figure of 7, urinary diversion, also for the urinary, for the orthotopic neobladder, but also for the ileal conduit. Yes, it is an option. You know, that is something, you mentioned that, your experience, patients should come to people that have the entire armamentarium. And if they don't have it, they should be going somewhere and learn about it so that they can offer the patients the prolongation of the ileum to the left ureter or the right ureter if they want to bring out the stoma to the left side. I've had those cases because you couldn't do it on the right side. And you know, and these things, which is, I think, is important for the patient because we have a wide variety. And the last thing I didn't mention is, and you know, in the orthotopic neobladder, always think about you're curing these patients, and that means 10, 15, 20 years of survival. They may have stones and other even recurrences of the upper urinary tract. Think about a method where you can get up to the upper urinary tract through the pouch, because otherwise, you know, especially if for a recurrence you have to follow these patients for a long time with endoscopy, then you will be happy not to every time have half an hour until you reach the ureteral orifice, find it and get to the upper urinary tract. Hope to have
Thank you
answered.
very much. Thank you very much. If I'm not hogging the, the platform, just a quick question, again, technical. Do you normally, in order to release the tension on your orthotopic bladder, do you mobilize the ileocecal mesentery to the treats, arcade, or just to release the tension or not?
Yeah, that's a very good question. You know, first of all, when you see the patient, before you start to doing your urinary, your orthotopic neobladder, the bowel that you need for the, try and see whether it goes down anyway. If it doesn't, if there is a longer distance between the mesenterial root and the urethral stump, which is more of a problem usually in the male than the female patients, think about how you open anti-mesenterically the bowel. You don't have to use it always exactly anti-mesenterically, but more on one side, so you get a longer spout, and that will help you. And the other thing is, you know, you really have to get out the entire bowel out of the pelvis. You know that, but you know, I've had patients during surgery, they were calling me and said, I can't get that thing down, you know, and I said, okay, get your assistant with both hands in and get everything up here. But with that, I did not have to incise the peritoneum of the mesenterium, because, you know, I think thinking ahead is better than incising it, getting bleeders, you know, and if you have a hematoma, then the vascularization of that bowel segment for the orthotopic neobladder may be compromised also.
Yeah, I think you're right. What I was referring to was the Cattell-Brash approach, you know, you like you indicated as part of that. Yeah, okay. Thank you. Thank you very much.
Okay, sure.
Professor Sazel, thanks a lot for your time. And we are all very grateful on behalf of both organizations for you to give up your time, sir. Thank you.
Thank you. Thanks for the invitation. Have a nice meeting. Yeah.
Thank you.
Okay. Thank you. Bye-bye.
Bye. So if we would just move on. Asha, thank you very much for your questions. And I think that's the whole idea. And that was very useful questions. We would just move on with the program, and if just wanted to ask our panelists and Professor Shamim Khan if it is okay to move on to robotic talk. Just finish our surgical block first. Professor Shamim Khan, if you are ready for your talk, sir.
Yeah, I can do mine.
So Professor Shamim Khan, Professor of Urology, Guy's in St. Thomas Hospital, King's College, London, does not need much introduction, and he will speak about robotics in cystectomy, evolution, and current evidence.
You forward it. So, firstly, it's a big honor to be invited to be part of this elite faculty from UK and abroad. So I will talk about robotic cystectomy. I've been asked to cover evolution and current evidence. Can you see the presentation?
Yes, we can see the presentation and we can hear you as well.
So thank you very much for kindly inviting me to be part of this rather elite faculty. Given me a very controversial topic, Professor Stenzel briefly touched upon it to defend this robotic assisted radical cystectomy, current evolution and current evidence. The surgeons love robots. I think those who are not surgeons, they must be wondering why is the case. I think surgeons have a bad reputation. They are known to have big egos and known to be control freaks. And Da Vinci robot, fortunately, offers some features which actually satisfy both of their traits. How it does it, basically, it gives them a 3D vision with the camera control. They are in full control, which allows them to navigate areas which are not easy to see, either in open or laparoscopic surgery. 3 arms to operate with rather than 2, as we see in open and laparoscopic surgery. Intuitive surgical movements, that means the movements inside the surgeon's console are exactly mirrored within the patient's body, which is in contrast to the laparoscopy. And lastly, and the most importantly, the wrist articulation, which facilitates easy intracorporeal suturing. There is no doubt that Da Vinci is currently the best available tool for minimally invasive surgery, benefiting both patients and, more importantly, also the surgeons. This is in sharp contrast to laparoscopic surgery, which can be regarded as surgery at the end of a long stick. There is no question the robotic cystectomy or radical cystectomy, whether you do it open or robotic, is the most complex, difficult operation, most morbid operation in urology. Because cystectomy has 3 components: removing the bladder, the lymph nodes, and most importantly, urinary diversion. How did it start? It started as a result of collaboration between Professor Ghanem and Mani Menon. I can just imagine what their discussion might have been like. So Ghanem telling Mani Menon that I'm using long incisions, which need long dressings. I put 2 of my hands inside the patient's belly to do the operation. My wound complication rate is about 15%. Transfusions are 30 to 40%. I have a lot of bladder cancer patients, but I do not have a robot. And Mani Menon, in turn, telling him that I use a tiny incisions. I use only band-aids at the end, 8mm instruments. My wound complication rate is about 1%, blood transfusion less than 5. I have few bladder cancer patients, but 2 robots. So they decided to bring the robot to Mansoura, and they did 17 radical cystectomies and published this in British Journal of Urology in 2003. Now, whenever you are starting anything new, the first step is the hardest, because then afterwards there is a momentum which follows. So that is what happened in robotic cystectomy. That same year, 2003, there was a publication of the completely robotic radical cystectomy and also orthotopic bladder reconstruction. Following year, another publication of the robotic intracorporeal ileal conduit. So if I talk about evolution, it has been nearly over 15 years. So we can say that robotic cystectomy has essentially evolved in 3 phases. The phase 1, where we developed the technique of the cystectomy and with extracorporeal urinary reconstruction. In phase 2, intracorporeal reconstructions, and phase 3, randomized controlled trials and long-term oncological outcomes. So another important event which happened in robotic cystectomy evolution is the establishment of International Robotic Cystectomy Consortium, which is headed by Professor Khurshid Guru. And I must say that this cystectomy consortium has helped a great deal in gathering substantial data on outcomes from around the world. They have more than 2,000 patients in their database. When we started our program in GUIDES in 2004, we published our initial experience with extracorporeal diversion in 2008 and subsequently analyzed our early complication rate in 2011. There have been numerous publications based on the data from International Robotic Cystectomy Consortium on various aspects of robotic cystectomy. In 2014, if you look at the UK database of radical cystectomies, 75% were done open, only 9% were laparoscopic, and 16% were robotic. If you compare the outcomes, the main things you will notice that the transfusion rates nearly were 30% in open compared to 10% in open laparoscopic and robotic. The length of stay was 4 days longer in open cystectomy arm, and the wound complication was 6%, whereas the positive margin rates were similar. The review published last year looking at outcomes from the USA and Europe just suggests similar outcome that blood loss is uniformly less in robotic cystectomy. The operating time initially was longer, but now catching up equal. Shorter in USA, 7 days, compared to Europe of about 10 days. But the shorter length of stay in America is counteracted by higher readmission rates of nearly 30% compared to 11% in Europe. Early complications, more or less equivalent, both open and robotic. So what did we learn from phase 1? That there was less blood loss, the scars were shorter, length of stay was shorter, and the complications were either less or equivalent. What was higher was the cost, and the operating times were longer. And what was equivalent was oncological outcomes. But you must remember that most centers until recently were performing urinary diversion through a small laparotomy that is extracorporeal. Then comes the phase 2. The objective of phase 2 was transition from extra to intracorporeal urinary diversions. The reason for intracorporeal urinary diversion is that you are using smaller incisions because you are not extending the incisions. You have less bowel exposure, blood loss is less. There's shorter operative time. Interestingly, the operating time is actually shorter when you're doing intracorporeal, and you have fewer post-operative complications. So we analyzed the results from the Robotic Cystectomy Consortium and also published our own results, and we demonstrated that it's easy to transition from extra to intracorporeal with very good outcomes, no difference in outcomes. As Professor Stenzel alluded to earlier, a lot of surgeons around the world has come up with their own versions of the orthotopic bladder reconstructions. But in guys at our center, we actually followed exactly the same design as Professor Studer described, and we do it with the robotic assistance. It is quite possible to do exactly the same, duplicate the same procedure. What is the disadvantage of the intracorporeal urinary diversion? That technically is more challenging. So the people who already have experience of robotic prostatectomy, for example, they might find it easier to straight away go to intracorporeal urinary diversions. Phase 3 was the randomized control trials and oncological outcomes. As we all know, that randomized controlled trials in surgery are not easy, because it's always in the first phase, people try to learn a new technique, and therefore rigorous evaluation is not possible. But fortunately, in case of robotic cystectomy, there has been 6 randomized controlled trials which has already been published. Of these 6 trials, at least 4 have looked at oncological outcomes, and 1 at complications, and 1 at quality of life. What have we learned from these controlled randomized trials? The trials are difficult. And the reason they are difficult, because the surgical procedures are not like pills that you compare one tablet with another or placebo, because a surgical procedure, there's a surgeon factor, surgical team factor, and pre and post-operative complications and care. So even the trial which is published in 2018 in the Lancet by Parekh and his colleagues is being criticized for several flaws. For example, that they were unable to blind the surgeon and the patients. Academic centers were the only one who took part in the trial. There were multiple surgeons, and the lymph node dissection and the neoadjuvant chemo was left to the physician's discretion. And lastly, pathological reviews were not centralized, and divergence were all extracorporeal. So even a trial which is published in Lancet has several flaws. So the community thinks that what is the problem in the previous trials, that they were mostly underpowered. They did not use enhanced recovery pathway, and diversions were extracorporeal. Therefore, what should be an ideal trial in robotics versus open cystectomy, which compares the totally intracorporeal cystectomy with open radical cystectomy, must apply enhanced recovery pathway, and there should be similar urinary diversions. So such a trial has just been completed in UK. It's called IROC trial. So the main centers which are participated in this trial, again, major academic centers, Sheffield, UCH in London, and Guy's. And the primary aim of this trial is the number of days patients are alive and out of the hospital within first 90 days from the operation, how they recover, and what is their complications. We will hear about these outcomes probably in a year, because they will publish the result after 1 year of follow-up. So what about long-term oncological outcome? There were a lot of concerns, particularly in early days, that probably the patients may have more recurrences if they have robotic operation. We were the first one from Guy's to publish our 5-year survival results from a random patients, but second time we published more recently from our randomized controlled trials, demonstrating that there is no difference between open, laparoscopic, or robotic oncological outcomes. These are our 10-year figures, which again suggest that the robotic cystectomy has equal oncological outcomes up to 10 years. IRCC published 5-year results and also 10-year results, demonstrating that oncological outcomes are equal, both open and robotic cystectomy. So evidence to date, as Professor Stenzel also said, that there is no precise, conclusive evidence that one is better than the other. And there is no evidence that the robotic cystectomy is any way inferior to open radical cystectomy. So if you look at the trends worldwide, in Europe, about 54% of the 56% of the cystectomies are being carried out by robotic approach. In America, 77%. What about UK? These are the UK figures. In 2014, we were doing about 16%, now 57%. So what is going on? Is people have gone mad that there is no evidence that one is better than the other, but yet the open cystectomy is coming down, laparoscopic is almost vanishing, and robotic is picking up. If you look at the trend in the worldwide of other specialties, in every specialty, robotic procedures are going up. So the key question is why we are continuing to do a procedure which hasn't proved that it is better than the counterpart. So devil is always in the detail. So what is the difference between open and robotic cystectomy? So if you take all these parameters of incisions, blood loss, post-op analgesia requirements, bowel function, hospital stay, post-op recovery, and wound complications, robotic is definitely doing better compared to the open counterpart, although may not be statistically different. What we have, where we have gone wrong, we have got unrealistic expectations from technology. I think we expected that because robot costs nearly 2 million, so therefore the difference between robotic, laparoscopic, and open will be a vast difference. But actually the difference is not that much. The difference is that of incisions, transfusions, infections, and length of stay. So just put to all the expert panel here, they're all experienced people, that I have 3 patients at the moment on my oncology ward. This patient is under gynecologist. She is 46 and had undergone open pelvic exenteration. 3 weeks after her operation, this is her wound. She's probably going to stay in the hospital another 6 to 8 weeks before this wound is manageable at home. If you count the cost of 1 per day hospital stay, is about 400 to 500 pounds, how much is going to cost us? Now, this lady is asking, could she have had the operation through a different approach that she didn't have this wound complication? She's otherwise well. This is another lady who is incidentally, again, 46, has been transferred from a different hospital. She is presented with a local hospital with a low swelling, cystic swelling in the lower part of the abdomen under general surgeons. And they thought she has an abscess. They took her to theater and they incised this abscess to drain it. And during the operation, they realized that they have probably made an incision or cut the bladder, so they put 2 stitches. So she was sent home to, after she developed this fasciitis. The wound is healing, so she was put on a catheter drainage and sent home, but catheter got blocked. when she went home. And when she catheter got blocked, all her urine started coming out from this hole. So she has a urinary fistula coming out of the abdominal wall. So the surgeons have transferred her to our center for further management. She's only 46. And lastly, I have this lady who is 82, has had bladder cancer since 2014. Over the last 6 years, she had multiple intravesical treatments. Now her bladder is completely contracted. She is going to the toilet every hour, day and night, and she needs an operation. So I'm asking you all, what would you do if you have an option of open versus robot? What would you do for these three ladies? So just to suggest that there are patients who really would benefit, particularly from a different approach rather than open radical cystectomy. In my experience, having done this operation for the last 16 years, which patients benefit most from robotic cystectomy? Those are females, if they are going to have ileal conduit urinary diversion, because you can take the specimen out of the vagina. Obese patients, those who are having palliative surgery can have cutaneous ureterostomies. Those with the poor performance status, and lastly, those who had previous radiotherapy and need a salvage cystectomy. So these are the patients who would benefit most from robotic approach. There is no question that robotic cystectomy, robotic surgery is expensive. And you all know that why it is expensive, because there's only one manufacturer who are dominating the market, but there are about 10 who are trying to come into the market. So hopefully the price of this procedure will come down. And if it becomes more reasonable, then people will start questioning you as to why not robotic rather than why robotic. But one sobering message to all those who want to embark on robotic surgery and going through the training, that its outcomes are not techno-specific, but surgeon-specific. And therefore, if you want to take this up, train yourself very well. Otherwise, you will have disaster on your hand. Remember that robot is just a tool to do the operation. It doesn't do the operation. You have to drive it. There is no question that surgical progress has been made with technological evolution, but technology is not going to change the biology. Biology is still the king. If you want to improve your outcomes in your centers, no matter where you are, no matter what approach you're using, perform surgery in high volume centers. It is best performed by 2 consultant level surgeons. Use minimally invasive approach if you can do it, enhance recovery, audit your outcomes, and work in multidisciplinary teams. Because in my opinion, the debate of the open versus robot is not a major issue in the management. It is about how we can use the multimodality approach to get the best oncological outcomes for these patients. So how we can work multimodal, multidisciplinary oncologists, whether they are medical or clinical scientists, open surgeons, laparoscopic surgeons, and robotic surgeons. We are very fortunate at Guy's to have a huge team of my colleagues who actually deliver service to our bladder cancer patients. As you heard a brilliant talk from Sheila. She is our anesthetist lead. What is my final message to the younger generation? Particularly, the robotic cystectomy has emerged as a minimally invasive alternative to open radical cystectomy. The main objective is it reduces the procedure-related morbidity. The best advice I can offer to the younger generation that embrace it and go with the flow, because technology is shaping our society and society is shaping the technology. So technology is not going to go away, but is only just one jigsaw which you have to actually solve to make the progress. But progress is not just with technology, but many other aspects, particularly in cancer care. And I thank you all for your attention, and I thank Almighty for blessing me much more than I deserve.
Thank you
very much, Professor Shamim Khan. Brian, would you like to comment on Shamim Khan's, Professor Khan's talk and a few cases that he has?
Can I
yes,
just...
I would, Professor Khan. That was an absolutely fantastic talk. You are certainly preaching to the converted. I'm a robotic surgeon. I would also say that not only should young surgeons embrace this technology, but also older surgeons. I think I was about 56 or 7 when I did my first robotic cystectomy, and I absolutely love it. I absolutely love it. And whatever the debate is, the academic debate about outcomes, is it better, is it not better? In real life, that ward round on HDU and on the ward, it is clearly better by a substantial margin in terms of blood loss, less transfusions, pain, less ileus. Recovery, length of stay is reduced from, in our unit, from a median of around 11 or 12 days down to 8. And so therefore it is clearly better. I had a couple of questions actually, Professor. One is, you mentioned in one of your slides that you encourage 2 consultants to operate together. Do you still do that at Guy's at the moment?
To be honest with you, not in routine cystectomies, but you know, the type of, when you have a high volume center, we do about 100 cystectomies a year. And to be honest with you, I think the patients who are coming for open cystectomies, I can tell you that those are the patients which are much more challenging now, because nobody wants to touch them in the periphery. So we have a very good collaboration with our colorectal surgeons. And if there are challenging cases where they have multiple laparotomies before, etc., it's a delight to work with as a team actually, because then they help you to take down the adhesions. And what you could do as yourself in 2 or 3 hours, they will do it in 1 hour, because that is their job every day. So that skill has helped us a lot. We help them to, so we do about 30 or 40 pelvic exenterations a year, and about 15, 20 joint cases with them, because these are the very challenging cases which have been transferred from other places. So this lady, for example, I showed you, she has T4 bladder cancer. So obviously it will be multimodal involvement of the plastic surgeons, the oncologist, the radiation oncologist. So we discuss each and every patient who comes to our bladder cancer clinic. We have a bladder cancer clinic once a week, which is attended by about 50 to 60 patients. And we have clinical, medical oncologist, the radiologist, pathologist, everyone in our pre-clinic MDT, where we discuss each and every patient before we go to the clinic, so that there's a uniformity of decision-making no matter who sees the patient here. But in complex patients, yes, I think we have a robotic fellow and in bladder cancer. So we have been, we had 5 or 6 fellows who have been trained with us, and actually they enjoy a lot because they get both open, robotic, and all variety of urinary diversions which we do. But when we do a urinary diversion like orthotopic bladder, for example, I think it is better that if you have another colleague and give you some breaks in the robotics. But for ileal conduit, we have most of our cases are done by the fellows once they are trained. And in those cases, we don't necessarily have 2 surgeons, but in more complex cases, yes, I think it is always helpful, yeah.
Thank you. I mean, I agree. It mirrors what we're doing in Middlesbrough. You probably know my colleague Joe Cresswell. We often scrub in together and give up our own time.
The robotic cystectomy a few years ago. before you started the program. So she joined me with a cystectomy. Yeah.
Zishan, can I come in?
Yeah, please, yeah.
Yeah. Hi, Shamim. Excellent talk, and full approbation for that. But I think being a non-robotic technician, I don't think in my mind there is any doubt, except for the cost implication, that the robotic surgery is a new transition. And I think this should be universally adopted. And I just give you an experience I had. I was visiting Lisbon just before the pre-COVID and saw one of the colorectal surgeons under the supervision of Professor Heald. And now, as you know, they are doing the ITMEs, which is the intrafacial, mesorectal transaction. And without robot, there is no way you can get the precision. And I personally think the questions that are being asked are simply because of the cost. And the request to you would be, all of you who have this possession of the expensive Porsche, if you could lean on to the company, and if somehow either the competition will bring the price down or whatever magic wand you could wave across, I think that is the big obstacle. But otherwise, in terms of technology, there is no denial, no doubt about its efficacy. And not only in urology, if you look at the upper GI, the colorectal, the pelvic work, and the endometriosis, there is no doubt.
Yeah, to be honest with you, there is an opportunity for us in Pakistan, because there is a robot in a civil hospital which has been moved to SIUT, and fortunately, we are fortunate to start the program. 2 years ago, we had a multidisciplinary workshop in which there were colorectal surgeons. There's a very famous colorectal surgeon who is working in Pool, Amjad Parvez, where he's originally from Pakistan.
He's the one I saw. He's the one I saw.
All right. So
amazing guy.
Amazing guy, and we are actually working together to promote the minimally invasive operation. The problem, Asher, is in case of cystectomy, people don't realize that it is not inside. We are doing the same operation, so we can't reduce the complications of inside anastomotic leaks or something like that, or obstruction, or collections. But it is not the inside; it is the outside. I think the wound complications are very significant in open cystectomy. People don't talk much about it.
So how are you going to wave the magic wand and the pressure to
at the moment, they are trying to increase at least the number of uses of instruments to about 15. So that will bring the cost down a bit. But other, Cambridge robot is already in several centers in UK, and I can honestly tell you the competition will drive down the cost. Yeah.
Great.
Okay. Thank you
very much.
Thank you again.
So we'll just move on. We're just running slightly behind time, and towards the end, those of us who wish to stay a little bit longer, we can have more discussion, because even as a non-bladder cancer specialist, I'm finding all this so interesting. So, but we'll just move on with our next talk, and Professor Syed Hussain, who has been waiting, and we will just go on to his talks on neoadjuvant treatment, and also radical treatment, why radiotherapy. So Professor Hussain, you would like me to share the screen and run the slide?
Yeah.
Right. Oh dear. Great. So.
Great.
Right. So, yeah.
Thank you very much. I don't know whether I can drive it forward or not, but anyway, we'll start with that. First of all, I would like to really...
I could do that, and you just please let me know whenever.
Okay, that's wonderful. Thank you very much, Zishan. Thank you to Royal College of Physicians and Surgeons Glasgow and Pakistan Association of Urological Surgeons to invite me and to be a participant in such an exciting meeting. I've really been enjoying the talks from Hamad Athar, wonderful talk, Sheila, a wonderful overview, and then Professor Stanzel and Professor Shamim Khan, as always, a delight to hear, really. So now I'll be giving a completely different perspective. I feel like I'm walking into a den now where the urologists are there who will tell me at the end of the day how bad what we are doing. And we should all turn and train ourselves as urologists for my next life. So without further ado, these are my disclosures. Next slide, please. So bladder cancer is a significant cause of morbidity and mortality. We are very much aware of how it really makes a big sort of impact on these patients. lot of deaths happen, the morbidity is there, and muscle invasive bladder cancer has a poor prognosis. So when I see my patients with muscle invasive bladder cancer, I do tell them that this is a life-limiting illness now. Professor Stanzel showed about the impact and the advances in, in the big centers, in German centers, and the median survival even post cystectomies and overall looking at 5-year survival still remains around 60 to 65%. And then there is a debate between primary cystectomy or organ preservation therapy. And again, that's where chemoradiotherapy has, I think, had a significant impact and improvement in outcomes when you're looking at organ preservation therapy. And then salvage surgery is an option as well. So those are sort of key things that we need to be aware of, that when we are offering patients organ preservation treatment, I always tell them that they will be remaining on lifelong surveillance and they will be having regular cystoscopies, and salvage cystectomy will one of the options that will be there. Next slide, please. Next slide.
I'm just trying to run through. Yeah, okay, great.
So moving on to neoadjuvant chemotherapy, I think neoadjuvant chemotherapy is one of the, I think it's a very important impact runners in muscle invasive bladder cancer. We are a big proponent of neoadjuvant chemotherapy. I always give the example of breast cancer, sort of a multidisciplinary team, where 2 to 3% adjuvant improvement in survival in the adjuvant treatment made a big impact in breast cancer practices. And we have seen significant improvement in survival by using neoadjuvant chemotherapy. This was, if you all remember, 2002 plenary session. There was a presentation looking at this paper, which was presented by, which was then published by Grossman et al. In New England Journal of Medicine, very clearly showing a 5-year survival, overall survival benefit of 57% versus 43%. What is very key here is that even with neoadjuvant chemotherapy, when you give these patients, or if you don't get neoadjuvant chemotherapy, the survival figures are still with chemotherapy about 57%, 77 months median survival. So there are a group of patients who we are losing with surgery, with or without neoadjuvant chemotherapy. And I think that is what brings home the point that perhaps other modalities of treatment like organ preservation should be looked at as well. And I think if you can go into the next slide, please. Then we have looked at the pathological responses post-neoadjuvant chemotherapy does drive the response rate and long-term survivals as well. It is considered a good surrogate endpoint that if you get a good pathological response from neoadjuvant chemotherapy, this may transform into improvement in overall survival. If you go into the next slide, and these are important slide because I wanted to show this MRC neoadjuvant trial, because while the Grossman study was a North American trial, which was only looking at patients who underwent cystectomy, and the median survival was 77 months versus 47 months. But in this study, there was about 400 patients who got cystectomy and 400 plus patients who got organ preservation treatment. That was radiotherapy at that time. And what was very interesting to see was that there was a consistent benefit of 6% survival benefit at 3 years, 5 years, and 10 years. At 10 years, the survival was 30% versus 36%, favoring neoadjuvant chemotherapy. So this 6% survival benefit, if you look at moving from 30% to 36%, and the absolute difference starts to become about 20%, in terms of the benefit that we are seeing with neoadjuvant chemotherapy. So when some of my colleagues challenge us and say, is 6% survival benefit with neoadjuvant chemotherapy big enough for us to drive things forward and use neoadjuvant chemotherapy before cystectomy? Because I completely take your point that while it can mop up micrometastatic disease, which is the rationale to use neoadjuvant chemotherapy, there may be a delay in radical curative treatment, a point that Hamad was mentioning as well, that I think there's a less uptake of neoadjuvant chemotherapy around in certain centers and certain countries as well. I feel that sometimes neoadjuvant chemotherapy may help you to select a subgroup of patients who are going to do poorly with metastatic disease. What you don't want to do is to perhaps do a sort of a radical cystoprostatectomy or cystectomy and anterior accentuation in a patient who might have micrometastatic disease sitting along, and they may come back to you within 6 months with a liver metastasis. So that is the reason that I feel neoadjuvant chemotherapy is important. I do take your point that we need to improve on the benefits from neoadjuvant chemotherapy. In terms of the chemotherapy we use, like gemcitabine and cisplatin, they're well tolerated. And in terms of medical oncology, clinical oncology, and the multidisciplinary team, we're reducing the morbidities related to chemotherapy, leading to better outcomes and better survival gains for these patients as well. Next slide, please. Yeah. So this is just, as I was saying, that 3 years, 5 years, and 10 years, if you look at overall survival, this benefit at 3 years, 50% versus 56%, 43% versus 49%, and 30% versus 36% improve with a hazard ratio of 0.84. So this is important, I think, improving on the overall survival in that setting. If you can have the next slide, please. I wanted to improve, how we're going to improve on neoadjuvant chemotherapy. We had some really interesting paper. This was Nature Medicine by my friend Tom PAUS. And again, looking at the Abacus study, which looked at 2 cycles of neoadjuvant atezolizumab treatment before cystectomy for patients who for some reason were declining or were cisplatin ineligible. 95 patients, 21 sites. PATH-CR rates was 31%. And I think what we learned from that was there are biological factors, and one thing which Professor Shamim Khan was talking about. And I think that is the key, which together as a multidisciplinary team, we all have to work together in trying to understand the biology better, to perhaps choose patients for neoadjuvant chemotherapy. Similarly, think about whether we can choose patients based on some of those biological factors between cystectomy and organ preservation. So transforming growth factor beta and fibroblast activation protein were linked to resistance. PURE-01 by Andrea Nachi. That paper had shown pembrolizumab in muscle invasive bladder cancer, 50 patient recruited, PATH rate 42% PATH-CR rate, and PD-L1 positive and high tumor mutational burden improved response rates, and the PATH-CR rate within that group was about 57% if they were PD-L1 positive and at high TMB board. This is NeoBlade trial, which is one of the trials I presented just at the ASCO GU, which was a large randomized trial national study that I led on, which was adding nintedanib into gemcitabine and cisplatin. Nintedanib is a VEGF inhibitor and fibroblast growth factor, FGF inhibitor. And again, we know that bladder cancer is driven by FGF inhibition as well. So this is something that was, it's a randomized trial, gemcitabine, cisplatin plus nintedanib versus gemcitabine plus cisplatin plus placebo. So placebo-controlled study. Can I have the next slide, please? So again, it was the way we did it was that patients were allowed to have cystectomy or organ preservation based on patient's choice or clinician choice. And then they had follow-up at 3 months and then further follow-ups with regular scans. Patient response assessment was done after 3 cycles of neoadjuvant chemotherapy with a biopsy as well, or at cystectomy, their PATH-CR rates were looked at. Next slide, please. So simple design, all basically histologically proven muscle invasive, T2 to T4 bladder cancer, GFR greater than 60, and if it was less than 60, between 40 to 60, then we did add a safety sub-study of phase 1 where we use split dose cisplatin, which is a regimen which I use quite commonly for patients with impaired renal functions. Next slide. So again, it was well balanced between more male predominance in that sense, median age around 68 and 69, GFR, in terms of like any other randomized setting, you will find they were well balanced. T2 disease was 61%, but they were T3A, T3B, so about 30% T3A, T3B disease and 7% T4 disease. Next slide, please. So again, gemcitabine 1000 mg per meter square, cisplatin 70 milligrams per meter square on day 1. And if it was to be split later on, it was added on in the trial. The split dose will be 35 mg per meter square on day 1 and day 8. Nintedanib arm with nintedanib, so there were fewer delays with nintedanib arm. But what was key thing to see is that your radical treatment, that was gemcitabine and cisplatin, the dose delivery was quite significantly not as what we would see with very similar to what we see in the placebo arm as well. Can I have the next slide, please? So primary endpoint was pathological CR. What was interesting was that pathological CR rates, whether you use nintedanib or placebo in combination with gemcitabine and cisplatin, was not very different. So the primary endpoint in terms of PATH-CR rate was not met in that sense. Can I have the next slide? What was really key was that the secondary endpoint of progression-free survival, which are much more robust endpoint, were significantly better. 24 months progression-free survival was 61% for placebo, 82% for nintedanib, with a hazard ratio of 0.468. And this translated into significant improvement in overall survival. If you could have the next slide, please, which very clearly showed a 24 months median survival, 89% in the experimental arm with nintedanib versus 69% for placebo. So significant improvement with a hazard ratio of 0.379. In terms of toxicity, they were generally well tolerated. One thing which we always worry about, neoadjuvant chemotherapy with cisplatin causing thromboembolic event. Many phase 2 trials with multikinase inhibitors have been stopped, thinking that in the triplet regimen, it's the multikinase inhibitor driving thromboembolic event. But within this randomized trial, we managed to answer that question as well, that actually it's cisplatin which is driving thromboembolic event, because the additional nintedanib did not significantly change in terms of the numbers that we are seeing with nintedanib versus placebo. So which was reassuring to see that additional multikinase treatment is not adding to thromboembolic events, which you can treat with anticoagulation, and patients did manage to go ahead with their planned cystectomy afterwards. Next slide. So in terms of otherwise toxicity wise, if you look at it, was a general what you see with toxicities, some hypotension, skin toxicities and things we saw, fatigue we saw, but nothing significant that you would see that you don't see with a doublet gemcitabine and cisplatin. So toxicity wise, things were generally well balanced between gemcitabine, cisplatin and nintedanib versus gemcitabine plus cisplatin plus placebo. Next slide, please. So primary endpoint of complete response rate did not show much difference, but secondary endpoint of progression-free survival and overall survival significantly improved. Safety sub-study showed that nintedanib dose of 150 milligram twice a day can be used with a split dose of platinum. It did increase, nintedanib increased grade 3/4 neutropenia, but did not otherwise lead to increased hospitalization, which was important to see that it did not lead to increased neutropenic sepsis. Thromboembolic events were well balanced. So I think what we can see here is that nintedanib with FGF inhibition and anti-angiogenic effects may have an impact on microenvironment. That is translating into improved progression-free survival and overall survival. And we're doing translational studies to study the biomarkers of response to enrich the patients who may benefit from this triplet better. And, I think this was a study which was seeking efficacy signals, which is showing extremely important clinically and statistically significant improvement in progression-free survival and overall survival. And there are plans to look at triplets and multikinase and combination with IOs as well to look for future. So I think in terms of neoadjuvant chemotherapy, it does look like we're making headways. And there are ongoing trials looking at gemcitabine cisplatin plus durvalumab versus gemcitabine and cisplatin in a randomized trial called Niagara. So moving on, please. So that was very much like what I wanted to leave you with neoadjuvant chemotherapy and move on to organ preservation. I don't know whether Professor Stanzel is here still or not, but I've got eminent urologists sitting here who are leading the field of cystectomy and radical treatment for bladder cancer. So it's great to have. So one thing which has always been put in, and again, I saw that in Professor Stanzel's talk as well, this stains data about 1,054 patients with 5 and 10 year survival of 60% and 43%. From Erlangen in Germany, Rodel had presented, published that data on 415 patients, and 5 year and 10 year survival was 51% and 31%. So if you look at on the abstract, this looks much inferior to the surgery. But if you look at in more detail in the minute detail, you will find that there were patients who could not have cystectomy or who were inoperable at surgery. They were excluded from the analysis. While if you look at like for like, the 5 year survival for muscle invasive bladder cancer for surgery was 47% versus 45%. So I think that's interesting to debate on. I always feel these are complementary treatments. These are not competing treatments. I think patients should have a choice about these treatment options as well. But very important point was, how do we improve on organ preservation? And that's something in UK we have led on for a while now. Can I have the next slide, please? So this is something we did phase 1 trial 15 years ago, almost 20 years now, looking at synchronous chemoradiotherapy using mitomycin C and 5-fluorouracil in combination with radiotherapy. One thing which I want to say to this audience, which I've said always, that this trial would not have happened without the help of some of the eminent urologists. So I had Mike Wallace, who really helped me in designing this study and helped me running this from phase 1 to phase 2 to phase 3. I remember the MDTs when Mike used to say that this is a patient not fit for surgery. Will you take him for your trial, Syed, with a bit of a wink in his eye. But gradually, when he saw responses were happening in T3B's patients as well, we started to get referrals of patients who were better fit patients as well, who could have had cystectomies, but patient wanted to have organ preservation. population. So this was important. And the phase 2 trial we had in British Journal of Cancer, which was in a bigger phase 2 50 patient data set, which showed that it was well tolerated with encouraging efficacy. And that led us to a phase 3 trial, which was funded by Cancer Research UK. And this was the trial. Again, if you can just, so this patient, the trial was basically looking at chemoradiotherapy versus radiotherapy. If you can just click on that, please, that will Zishan, that will just bring them over. Yeah, so 458 patients were in total recruited, but 360 patients is the one that we'll be talking more about, who were randomized between chemoradiotherapy versus radiotherapy. So 182 had chemo-RT, 178 had radiotherapy. The other part, which was looking at full bladder volume radiotherapy versus partial bladder volume, did not recruit as well and did not complete. But the main part of this talk that I will be talking about in the BC 2001 is looking at chemoradiotherapy, which is mitomycin C plus 5-FU plus radiotherapy versus radiotherapy alone. And I will let you know, I will say that 118 out of these 360 patients had neoadjuvant chemotherapy as well. So even in that part of the, sort of talking about 2001 to 2008, we were giving neoadjuvant chemotherapy. 1/3 of our patients received neoadjuvant chemotherapy. Could I have the next slide, please? So this is how the primary endpoints were looking at: local regional control, late toxicity to detect 15% improvement with chemoradiotherapy at 2 years, hazard ratio 0.62, and to detect 15% reduction in the toxicity with the radiotherapy comparison only. But that part of the study did not continue for recruitment, but CRUK funding continued for the chemoradiotherapy versus radiotherapy part of the trial. If I could have the next slide here. So acute and late toxicities were being looked at, bladder capacity, quality of life. And again, lots of these things like bladder capacity was something my urology colleagues always used to talk about, which I learned from, because if you're preserving the bladder, if it's a non-functioning bladder, there's no point in keeping that bladder. And I think that was important. Salvage cystectomy rates were also to be looked on in the phase 3 trial, because we had seen from a phase 1-2 trial that salvage cystectomy is manageable and patients can have this bladder out when they get recurrence. And again, one key thing which I mentioned at the outset is that it's a complementary treatment. It's important for patients to understand that if they're going for organ preservation, they need lifelong surveillance, and they will require the urology support to make sure that they are having cystoscopies regularly. And if they get recurrence, they can have cystectomy if they're still well and fit for cystectomy. Next, yeah, so platinum-based neoadjuvant chemotherapy was permitted. 3D conformal radiotherapy, 55 grays or 64 grays were allowed, and reduced high-dose volume radiotherapy I mentioned about. Chemotherapy was mitomycin C 12 mg per meter square on day 1 of radiotherapy, and 5-fluorouracilus continuous infusion at 500 mg per meter square over 24 hours for 5 days, corresponding to fractions 1 to 5 and 16 to 20 of radiotherapy. Next slide. So follow-up assessments, the late toxicities were done at 6 monthly, 9 monthly, and 12 monthly, and their functional assessments for cancer therapy and baseline end of treatment quality of life questionnaires were done as well, which we have recently last year published in European Urology. So they were well balanced, as you will expect. These patients, more sort of T2 patients, but there were T3A, T3B patients as well. There were patients who had residual mass post TURBT as well. And neoadjuvant chemotherapy, as I said, was given in about 30% of patients. 40% of the patient had 55 grays, and 60% of the patient had 64 grays. So this was published in 2012, which was a practice-changing study, which is now used in countries nationally and internationally, and European sites, and in lots of Asian countries where I've been to, where basically mitomycin C plus 5-FU is added into radiotherapy in view of the results. If you can have the next slide, please. And the results were quite clearly showing that with a hazard ratio of 0.68, there was improvement in local regional disease control, which was the primary endpoint, but invasive local control almost half. So the hazard ratio was 0.57 for invasive local control. In 2012, when we published that data in New England Journal of Medicine, overall survival was not seen. And I can tell you, which is in later slides, we'll talk about that more recent updated analysis has shown bladder cancer specific survival in patients who had chemoradiotherapy. So this was interesting data that we saw. in terms of the hazard ratio, if you look at this forest plot, irrespective of whether you had whole bladder or modified bladder, but very importantly, whether you had 55 grays or 64 grays, or whether you had neoadjuvant chemotherapy or no neoadjuvant chemotherapy, patients were benefiting from the chemoradiotherapy arm. So that was interesting to see that patients were benefiting from neoadjuvant chemotherapy, irrespective of whether they had different fractionations or whether they had neoadjuvant chemotherapy or no neoadjuvant chemotherapy. And the late long-term phase data that we presented at ASCO GU, if I could have the next slide, please. That again very clearly showed that looking at 2012, when we published that paper in New England Journal of Medicine, and the more recent, the last snapshot which was done, where about 70% of patients have died, and that was very much like the final analysis that we had done. Very clearly, we are seeing that this local regional disease control, if I can have the next slide, please. The local regional disease control that was still benefiting in terms of long-term control as well. If I could have a couple more, yeah, thanks. So 68% versus 54% we saw in 2012 when we published in New England Journal of Medicine, and this is something which we're just submitting to Lancet Oncology now, which is looking at 63% versus 49% at 5 years. So the benefit that you're seeing in terms of local regional control, that is long-term, we are seeing that. If I could have the next slide, please. And that is invasive local regional control. That is, again, showing benefit. In the last slide, you saw one was non-invasive and one was invasive local regional control. And this is overall survival. So what we are seeing is that overall survival, 49% versus 37%, which is not statistically significant. But if you just click on again, Zishan, there will be bladder cancer specific survival, which is showing a significance in terms of p-value 0.04, 44% versus 58% at 5 years. And again, we need to understand these are elderly patient population in their 70s, and they have competing comorbidities as well. So I think it's important to look at these in terms of bladder cancer specific survival as well. So with 10-year follow-up, an improvement in local regional control and a reduced salvage cystectomy rate was confirmed with chemoradiotherapy. Adjustment for known prognostic factor, this results in an improvement in bladder cancer specific survival. Radiotherapy volume modification used did not reduce toxicity, but there was no evidence of an increase in local failure rate. And these updated results support the use of chemoradiotherapy with 5-fluorouracil and mitomycin C, and confirms this should be a standard of care in muscle invasive bladder cancer. If you have next slide, please. In UK, there was another study by Peter Hoskin and the group, which was published in JCO, which used carbogen plus nicotinamide, which again showed improvement in overall survival with a p-value of 0.04 as well. So using these hypoxic, driving the hypoxia down by having this carbogen and nicotinamide, that was the rationale for using carbogen and nicotinamide did improve the outcomes as well. So I think these are important. I think there are other options as well, like you can use gemcitabine, which has again been published in JCO as a radiosensitizer. One thing I want to make it very clear that the agents that we are using are as radiosensitizers. And that's why perhaps we don't see that much impact on overall survival, because you'll see survival benefit more with neoadjuvant chemotherapy, where you're using the right doses to have a big impact on micrometastatic diseases. These drugs that we're using are more as radiosensitizers to improve the efficacy of radiotherapy treatment. And I think that's why when we look at these data, we always look at local control as the primary endpoint, not as overall survival. But again, to see overall survival, bladder cancer specific survival coming through with some of these studies is encouraging. But I think neoadjuvant chemotherapies are key. I think if you go to the next slide, I think one before, yeah. So I think we have talked about this tumor biology, and I think this is what's going to be driving things forward. And I think looking at different classification, we are no more talking about just muscle invasive and T2, T3B, T4, because it's not just a pathological classification, but it's the biological classification. It's the, that's where translational medicine is going to help us. So now we have subclassification of bladder cancer, luminal papillary, luminal infiltrated, luminal, basal squamous, and neuronal based on the biomarkers. And that may help us to try and basically select patients who might more benefit from neoadjuvant chemotherapy, patients who should go perhaps straight to cystectomy, and things like that. Okay.
And you've got really good maths in there from
Sorry, Professor Sen, you might have to unmute yourself. Sorry.
So basically, this is what the tumor biology is telling us and moving us towards. And we in UK, if you can go to the next slide, my colleague James Cato, myself, and Simon Crabb, we have got this grant from NIHR, which is a big grant to look at basically genome stratification, use of neoadjuvant chemotherapy in bladder cancer. And the patients who are fit for chemotherapy and all radical options, they will be having these subclassification based on genome stratification, and the primary endpoint will be looking at PAT-CR rate. So initially it will be a feasibility phase, and then it will be a, to see whether this has an impact on outcome where we can select patients as well. So I think those were the key things that I wanted to discuss really very quickly today. I think if we could just have the last slide. And I think that's the key. I feel quite strongly that if it were not for the great variability among individuals, medicine might as well be a science, not an art. I do really believe in it. And I think as a multidisciplinary meeting, Zishan and the team who has organized this meeting is phenomenally successful. I have learned a lot from all of you. And I think it's important that we all work together. I think it was great to have an overview from Pakistan, from Hamad Athar, to know about what's going on. I think anything we can do to help improve neoadjuvant chemotherapy roles and things like that, and better treatment options for patients around globally as clinical academic, that I see as my role, and I'm always available for these. Happy to have any questions being thrown to me by email or whichever way today or later on anyway. I will stop here, and again, thank you.
Thank you very much, Professor Sen, and it was a very evidence-rich, wonderful talk. I just feel we could, if you could finish the talks, just in case our speakers have any commitments, and then I'm sure there's a lot to discuss, and those of us who could stay a little bit longer, we could come to that. So for our next lecture, we are very grateful to Professor Saeed Akhtar, who is here with us, Chairman Urology, PAF Hospital, and Clinical Professor, University of Vermont, who is going to give us a lecture about urinary diversions, patient selection, and outcomes. Professor Akhtar, please.
Thank you so much, and it's been a great talk and great session that we are honored to be part of. Appreciate you inviting us, and thank you so much. So basically, once the surgeon has done his job and bladder has been removed, we have this situation where pelvis is a clean pelvis, and we have also dissected the urethra. And the question is what to do next. And here, I think it's important to describe that we don't use the diversion only for bladder substitution in cancer cases, but there are a lot of other indications that are required, for example, extrophy, urogenic bladder, high pressure, etc., etc. So obviously, the commonest use of the urine diversion is post-radical cystectomy, but one needs to understand that there are other indications, and I think that's why it's very important to have an overall concept of the urine diversion and see what's the best way of diversion in different situations. So when you talk about urine diversions, there are two basic types of urine diversion. Content, where you have no control and it just drains into a bag, and that is done either through ileal conduit, colonic conduit, cutaneous ureterostomies, or pilostomies. And remember, these conduits are actually, these are just drain pipes, so they comes and just drains out of them, while the other form of diversion, which is the content diversion, actually needs a creation of a reservoir, and the reservoir needs to have a mechanism that gives us contents. So there are three pillars of that constance mechanism. One is the external urine sphincter, and all forms of orthotopic neobladder, and orthotopic neobladder means the bladder in its own place, either made out of ileum or colon. So this comes to like Stewart's pouch, Mays pouch, hemicolon, right colon, iliocolon. So there's a whole variety of combinations that have been evolved. Then there are places where the urethra cannot be used, the sphincter cannot be used, and we end up making catheterizable reservoirs from colon or small bowel, and they are like Indiana pouch, Leahy pouch, Hope pouch, Mains pouch, Florida, etc. So I'm not going to worry about these names, but The concept is that these are a bunch of different pouches with one difference over the other, giving it a different name. The principle remains that either they use ileocecal valve, plicated ileocecal valve as a continence mechanism, or ileocecal interception as a continence mechanism, or Mitrofanoff principle using appendix in a subcutaneous tunnel. And then lastly, that we don't use so much now is the anal sphincter being the seat of continence, and here we're talking about the main stew pouch, Mensura pouch, or uterus sigmoid. So what is an ideal bladder? Low pressure, adequate capacity, preservation of upper tract, no infections, no leakage, and socially acceptable. So these are some of the characteristics that we need to aim for when we talk about substituting the bladder. And the most important thing is that since we are using intestine, and intestine absorb a lot of stuff and secrete a lot of stuff, so we need to make sure that is this patient a good candidate. And so that's why one of the primary thing is what's their serum creatinine or the creatinine clearance, and can they really acidify? So we used a benchmark of 2 as a creatinine is 2 and creatinine clearance of 35 or more as and creatinine of less than 2 with a good acidification function and a good osmolality with the water deprivation. The other thing you want to do is when you're creating these reservoirs, you want to make sure that there are no major pockets, because these pockets then become seat of stones and stuff. And the most important principle of creation of all these pouches, whether you're using external sphincter as a mechanism of continence or catheterizable stoma, the detuberization is the name of the game. Otherwise, they will generate a very high pressure and they will destroy the upper tract. And here is a good cartoon to show you that in a tube, which is a long tube, once you fillet it open, divide it into 2, they become into 2 ribbons, sew them parallel. So not only it gives you a higher volume, but it also decreases the pressure. So it's a topic of its own discussion, but certain principles are very, very important. Good exposure, good blood supply. You don't want to spill the enteric content into the cavity. Good apposition of the anastomosis, no strangulation of the tissue, and realignment of the mesentery. So these are some of the fundamental principles. But you have to remember that no one procedure is the best procedure. It has to be tailored at the need, to the time of the patient, extent of the disease, and what's going on in the operating room. So never, ever, ever, ever promise somebody that that's the only thing I'm going to do, because things may change on a changing situation in the operating room. But you must discuss all the options and try to do the best. So conduits generally are simple, straightforward, less mobility, less operating time. Catheterizable pouches are the most complex, and the orthotopic tube bladders are somewhere in between. But the most important thing is do what you think you're most comfortable with. So orthotopic bladders are ideal, provided there's no malignancy in the prostatic fossa on preoperative staging. Biopsy of the TCC sphincter mechanism is not compromised, like by previous TUR and stuff. And urethra is a usable urethra with no stricture. And sometimes in very, very obese patient, mesentery is so thick that it's difficult to bring the valve down. And also these guys actually void by relaxing themselves. So you should tell them that it's like learning how to ride a bicycle, and they should also be counseled for clean catheterization. Catheterizable conduits should be only done on those patients who really understand they are taking a responsibility, because if they don't empty the reservoir, it's just going to rupture and create a catastrophe. And I've seen one of my patients in whom I had to undo the Indiana pouch and make a little conduit because she was drunk and came to me with the bladder full of 1,300 cc's of urine and didn't deserve such a amount. So manual dexterity is extremely important. So you can do it in paraplegics, but you can't do it in quads. So understanding the vascular anatomy is extremely important, like anything else in life. And most of the right colon reservoirs that we created in the pedicle of ileocolic and right colic, and most of the sigmoid conduits that we do it on the left colic branch, which is a sigmoid branch. And more important than that is actually when you're doing these, you have to understand that looking at the mesenteric window and see where you're going to take the bowel from. So you want to take the bowel from here, you want to leave, go to the second or third arcade, and you want to make sure that, so for example, if you're taking this pouch, maybe this is a good place to sever the bowel and the mesentery and leave this vessel inside, and maybe this is the place. So again, make a good decision how you're going to take the. So ileal conduit is a time-tested procedure, almost 100-year-old, but more popular for the last 70 years. Described in 1950 by Bricker. Bricker really popularized it. About 10 to 15 centimeters of ileum. Always remember, it has to be isoperistaltic, not antiperistaltic. Otherwise, there'll be horrible metabolic issues. At least 30 centimeters of distal ileocecal ileum you have to leave, so that vitamin B12 is not an issue. Typically, a refluxing fish bowel related anastomosis. The contraindications is short bowel, inflammatory bowel disease, pelvic radiation, sometimes extreme obesity. So straightforward procedure, you take about 15 to 20 centimeters of ileal conduit, re-anastomose the bowel, close the mesentery, close this end of the ileal conduit, and then bring this out and hook the two ureters in the back of the ileal conduit. Easy said than done, but it's a simple procedure. These are the straightforward anastomosis. This is a Wallace where you put two ureters together. I don't like to do that in cancer situation because of the recurrence of the cancer in one of the ureters. We have seen a couple of them where, so you have to undo the whole thing. So in cancer, I would not want you to do a Wallace procedure, but in neurogenic bowel, etc., Wallace is a good technique. And then you make a good nipple, a good eversion, so the back fits well. And in very obese patients, you do what is called as a turnbull anastomosis. And the turnbull basically is turning bringing out the knuckle of the bowel outside and then just sewing it on its own. And so this is just a defunctional hole, and this is the functional hole from the urine comes out. This actually saves the devascularization of the stoma in a very obese patient. And this is how a nicely done radical cystectomy should show a nice nipple. In certain cases where the bowel has been badly irradiated, you may want to go towards a transverse colon conduit or even a sigmoid conduit. They are relatively less common, but there's always a choice, especially where the bowel is really badly irradiated. So this is sigmoid mesentery, and this is pouch, or the not pouch, the segment that you have identified. Close the proximal and the distal end comes out, and through the skin and the uterus has to move. So coming to the orthotopic bladder, it's something that you learn with more experience. So before you go to the bladder side, it's extremely important that you do a very, very delicate and good dissection of the apex of the prostate and the urethra that you're going to leave behind. You have a choice of the bowel segment, typically ileum, but we used to do at one time sigmoid colon, but because of the high pressure, nobody does that anymore. But that is one of the options. There is a risk of recurrence of the cancer in the urethra, and if it's a locally advanced tumor, you don't want to do that because if you think the bowel will receive radiation later on as a multimodal treatment because of the advanced disease, this is not a good choice. So age may not be a contraindication, but again, choice of what's going on in the OR, function, body habitus, manual dexterity, as these patients still may require self-catheterization. Previous irradiation is not a good option for these segments, and prior prostate surgery or bowel resection. So all these orthotopic neobladders came through an evolution. You may initially describe, you just simply took this segment of the ileum, hooked it into the urethra, put one ureter on each limb, but they were not detubularized, so very high pressure, very high leakage rate. And he came up with Cabet 2, where he closed these and made it to one reservoir. But in this day and age, the commonest procedure that most of the people are following is a Studer's pouch, pretty straightforward to construct. Again, you take about 45 centimeters of the ileum, leave a chimney as isoperistaltic segment to prevent the reflux, and then you open it, detubularize it, sew the posterior wall, sew the anterior wall, and then at the bottom of this, you connect this to the urethra. So at the end of the procedure, you have a pouch there with 2 urethral catheters, maybe 1 malacord coming out as you back up with the end-to-end anastomosis between urethra and the same thing goes with the sigmoid. I say this for historical reasons, but we don't do this anymore. So this is the coke pouch that it was described as coke and the hemicoke pouch. Here, this is the continent nipple. Here, this is a continent nipple, and this is a small intestine. And the continent nipple, you can bring it to the skin, or you can connect it to the urethra, the hemicoke pouch. These are more complex to construct, and I've done a bunch of these, and a lot of problem. These meshes will erode, and one of the things that really you have to do is you have to intercept this and fire a bunch of staple lines, and then again put a mesh behind to preserve the interception. So they're more technical, they have much more complication rate, and not easy to do. So then there's a W pouch. Again, this is a poly GIA stapler. This is made out of absorbable steel. These are not metal staplers, and you can fire them from this side, one from this side and one from this side, and then you create a pouch, and then you put the urethra through. So again, they are large. This is not the time to go into details of every procedure, but this is a concept giving lecture. There's a whole bunch. But as a urologist, you need to understand, again, there's an ileocecal reservoir that you take distal ileum and the descending colon, detubularize them, turn them over to each other, and bring them down to the sphincter and put the urethra into it. So again, the idea is to give you a whole overall concept. And then there's a bunch of continent catheterizable pouches, and with one difference or the other difference, there are a whole bunch of name difference. So I don't want to bother you with this name, but the fact remains that there's ileocecal valve and the appendix remains. The commonest one is the Indiana pouch, which is the most popular that I do in my patients where I can't use their sphincter mechanism as the catheterizable stoma. But it's more difficult and complex to make. So you detubularize the colon, fold it on itself, and then again you create this distal ileum as a catheterizable nipple, and then you plicate. And this is a very important step here, where you plicate using a silk this distal ileocecal junction, so that there's no leakage, and then you put the ureters in a non-refluxing fashion into the tinea, and then you close the valve over the ureter into the tinea, and this becomes a non-refluxing anastomosis. Mains one was the pouch. Again, this uses interceptive ileocecal valve as a mechanism, but again, all these mechanisms where you use interception and use staples to sort of hold interception in place has its own problems and erosions and whatnot, and especially. So then this is the Leahy Clinic that described this again. A very similar mechanism, right colon pouch, where you can fold it on its own, and here you use the appendix and you bury the appendix into one of the tinea and bring it to the skin, and then use the ileum put the ureters. I've done this in a bunch of those patients who have neurogenic bowel with very, very dilated ureters that you cannot put in the tinea, and this procedure works very well, but you have to have a long appendix, long enough to bring it to the skin. So this is one of the guys that we did an Indiana pouch for extrophy of the bladder, and the most important thing I want to show here is this is the terminal ileum, and you want to trim it, and then once you have trimmed it, this is the nipple which is ready, and this is the malacord catheter into our Indiana pouch, and then here we have filled up the pouch with the malacord, and we are trying to push and see if there's any leakage of any urine that you test, and if there is one that you want to, and then this tube comes out of the nipple. There's a malacord catheter. These are drains, and they are the urological catheters. So pretty complex pouches to create, but very rewarding results. And these are the post surgery. You do your pouchogram and urotogram before you remove the catheters. And and this is one of the lady who had a syringomyelia, so done for a neurogenic bladder. So coming to the conclusion, all these procedures are extremely useful procedures that every urologist, especially I'm addressing to the younger lot now, that they need to understand, and they need to understand the complications. So the complication could be urinary leak, bowel leak, and bowel leak is disastrous complication. So is urine leak, but bowel leak is worse. So you have to be very careful with your anastomosis, stomal necrosis, stomal bleed, then peristomal hernias, stomal stenosis, stomal retraction. Conduits can become shrunken and stenotic, etc. Upper tract dilatation, renal impairment, and that's why I always counsel them. That I followed some of these my patients long term who have developed renal deterioration, and they've gone on to after 20 years they have gone on to dialysis. So that is something that you have to. And these are cancer patients who are cured from their cancer, needing some dialysis, pyelonephritis, metabolic complications. So one thing which is very important is when you're doing this, you're almost like getting married to your patient, and you need to follow them up throughout the whole life, especially when you do the content reservoirs, and you need to really watch for the metabolic complication. So in conclusion, I think all these forms of urinary diversions are a great tool in our armamentarium for cancer and other diseases requiring bladder substitution. I think use of intestine in GU tract reconstruction is a very important topic that should be given much focus in our urological training. Just like any other reconstructive surgery, they require good understanding of all the options and what is the best for the patient. Precision, gentle handling of the tissues, no tension of the anastomosis, no twisting of the mesentery or the ureter, good understanding of the vascular anatomy. You don't want to also devascularize the ureters when you're bringing them out. Repositioning of the bowel in normal anatomical position. So when you're closing the belly, I mean, everything in cancer surgery, like big surgeries, it requires attention to detail. So you can't just shove the bowel in and just close the belly. You really need to position so there's no internal herniation in the And you also have to have a good knowledge of stapling devices like a GIA. Poly-GIA is the stapler which uses the absorbable staples, and EA, end-to-end anastomosis staple. Use of intestine and its surgical handling and management is a very important aspect of urological training in bladder construction, ileal ureter, or even vaginal construction, and we have done a couple of those. So it's very important that if in your center you're not dealing with how to handle the bowel, you should go out to a general surgery program and get yourself trained. So in conclusion, I think urinary diversion is as important as doing radical cystectomy. It is extremely important to pay attention to detail. It is extremely important to understand the physiology of the patient and the physiology of the bowel and what can be the potential outcome. And the right choice, right selection is the name of the game if you want to see the successful outcome with the long term. Thank you very
much. Thank you very much, Professor Akhtar, for very nicely demonstrated pictures and your lecture. Please, we would just move on to the last lecture, and that's on the follow-up and patient journey in the community, and that might be a good continuation of some of the points in Professor Amar's talks at the beginning. So our colleague, Mr. Ghulam Mustafa Nanwani, consultant urological surgeon in Nine Wells Hospital, would just start that talk, please. And I just also wish to mention to all the participants that I'm not sure whether the meeting might abruptly finish at 1 o'clock, but I've just set up another meeting from 1 in case if we extend 15 minutes, and I'm just going to share all that in the participants link. So please note that. I'm not sure whether it will send that. Right, okay. So Mr. Mani, please, if you want to just carry on. Thank you.
Hi, good afternoon all. Namaste and assalamu alaikum. Are you guys able to see my screen now?
Yes, we can see your screen and hear you.
Okay, so I'll be more quicker now. So I'm very grateful for the organizing committee for the invitation of the talk on this subject. Zishan has already introduced me, so I'll move on to my next slide. So what I want, what are the bases of the follow-up? As part of the cancer management, follow-up after radical cystectomy is necessary. Physical examination detects or visible abnormalities, hernias, wound, and stoma problems, and also assess the quality of life. And then the second is the detection of the local or the systemic recurrences and cancer in the remaining upper part and the urethral remnant. Functional monitoring to assess flow dynamics of diversion, continence, voiding issues with complex reconstructions. Blood investigation to assess hemoglobin, renal functions, nutritional deficiency, and metabolic acidosis. First few things about the recurrences. So despite all the best efforts and successful multimodal treatment, cancer recurrences occur. 5-year recurrence-free survivals are reported overall is 50 to 60%, and which is dependent on pathological stage, lymphovascular invasion, CIS, margin status, lymph node involvement, and type of the tumor what we are dealing with. Local recurrences, that is in the true pelvis, at the bladder bed and the pelvic lymph nodes areas, occurs around 18 to 35% of patients, and the median times are reported between 7 and 18 months. While systemic recurrences, that's above the true pelvis in the lungs or liver or bones, that occurs in 20 to 35% of patients with median time again under 12 months. And it is seen that most of the recurrences, whatever the pattern we have, it occurs within 2 to 3 years time. And it is debatable whether detecting asymptomatic recurrences is beneficial. However, the detection may initiate a process of discussion on available treatment options and possibility at a low volume rate. And I saw there were some talks from the it's like a small volume disease. There is some like a surgical options can be done. It was in the Prof. Stenzel's talk. Upper tract recurrences are reported around 0.75% to 6.4%, and the median times are quite variable between 3 months to 160 months. Variability in times is possibly related to associated risk factors like CIS, pathological T-stage, and margin status. Usually these are detected on surveillance imaging, but patients also present with symptoms of pain and hematuria. In majority, it is detected as part of the advanced disease. However, around 1/3 may have isolated recurrences, which is possibly amenable to radical surgery. Urethral recurrence occur in 2 to 6%, usually within 2 years' time. Patients with involvement of prostatic urethra, CIS, and bladder neck tumors are at risk. Also detected usually on surveillance of the urethral remnant. And if detected, options are usually urethrectomy. Benign problems, stones, can be found in 9 to 11% of patients with higher, and incidence of orthotopic and continent is higher.
Your voice is breaking up, so just need to be closer to the.
Okay, so this is related to metabolic changes due to patients' own risk, due to acidity related to exposure of urine to exposed bowel surface. In addition, the patient's own risk factors also contribute to this problem. Stones can be found in the kidneys, ureters, and reconstructed pouches of the bladder, and these are detected on symptoms on routine or on routine surveillance and treated according to their merit. Benign stricture rates vary between 2 to 15%, and the main risk factor is the ischemia, and the rates are different with type of a ureteroileal anastomotic techniques, and usually detected on routine surveillance or assessment of the symptoms like pain or worsening renal function with a background of recurrent infections. Infections after cystectomy is also occur, and workup is required to rule out the above possible causes. Hernia and stoma related problems are also found, and more than half are detected in later part of the follow-up. These are obviously identified on physical examination and can also be detected on imaging. Blood investigations usually detect in the early part of the follow-up. Anemia is usually related to iron deficiency, and later part vitamin deficiencies can play a part. Regular renal function check is essential, as all patients, regardless of divergent type, are at risk of deterioration of renal function. blood pH monitoring, bicarbonate, calcium are useful to assess metabolic program in patients with orthotopic reconstruction and continent pouches. Imaging practices in surveillance. There are various imaging resources, ultrasound to cardiogram, to CT, urogram, and MRI are used. It all depends on local practices, patient profile, availability of resources. In our setup, CTU and CT chest is found to be more feasible and informative with less need to repeat imaging. However, patients with allergy and severe chronic disease are considered for non-contrast CT or MRI scan. What we have understood so far, majority of cancer recurrences occur within 3 years and majority within 2 years. Blood and benign abnormalities usually occur late. CT scan is the key investigation which can detect any of the above said. We should concentrate our surveillance resources and efforts in the first 3 years' time. Now need to look at what is available for guidance. If you see the EAU guidelines, CT, chest, abdomen, pelvis is recommended, but exact timing is not mentioned, and imaging should stop after 5 years. Urethral remnant surveillance is recommended in patients with high risk for urethral recurrence. Assessment of metabolic acidosis is recommended for reconstructed bladders, and vitamin level assessment, particularly B12 levels on annual basis. In AUA guidelines, CT, abdomen and pelvis, chest, abdomen and pelvis without MRI 6 to 12 monthly for 2 to 3 years, and then continue annually. Blood testing 3 to 6 monthly for 2 to 3 years, and then annually on surveillance of urethral remnant is recommended. NICE guidance, almost same things are mentioned in the NICE guidelines. The CT, chest, abdomen, pelvis, and urethral remnant surveillance for up to 5 years. What are the learning finds from these? Imaging is recommended in all guidelines. Important time period is again between 2 to 3 years time. Surveillance could be stopped after 5 years. Screening for upper tract is also recommended. Urethral remnant surveillance is also recommended. Bloods, in addition to routine vitamin and acid assessment, is also recommended in selected patients. How to do follow-up? Traditional way of follow-up is like a face-to-face consultation, which makes a good rapport with the patient. Patient can be assessed physically and physical abnormalities can be detected. It's expensive and time-consuming as required staffing resources, patient transport, alteration in work arrangements for patients, family members, resulting in loss of work. Does all patients need this type of follow-up? Possibly not. And who should be following the patient? Is it the urologist? Can we incorporate a specialist nurse, or can we transfer that follow-up into the community team? Telephonic consultation, and these are the quicker way of follow-up, but physical assessments of a patient cannot be performed. Good method, particularly for updating results, less expensive due to factors as discussed in the previous slide. Again, is this modalities for all patients? Obviously, some people who have hearing problems or difficulty in understanding the conversation, they are not suitable. Third is which is usually getting more popular, is the video consultations. It again makes a good rapport with the patient. Physical examination is not possible. However, it is less expensive than the face-to-face consultation, and the review and the feedbacks from the patients are very good. And it relies on the good IT skills of the patient and available internet facilities. What we do here in the cystectomy patients, so our population is small, but catchment area is large, and there are larger distances and some people may have to travel 80 to 90 miles to reach to the hospital. So what we do are 2 to 3 weeks after cystectomy, we review them in the clinic, which is a consultant and the specialist nurse review clinic. Here we make a decision of the extent of follow-up on after assessing his comorbidities and current ECU status. Actually, what we are going to gain from follow-up and how we should perform. Subsequent follow-up by defaults are our telephonic follow-up with the specialist urology nurses, 6 monthly till 5 years, where they assess holistic needs assessment, talk about their stoma management problems, and they also keep an eye on their community support with the supply of appliances. For surveillance, I usually do the CT urogram and CT chest on 6 monthly basis for 3 years, and then annually, and stop surveillance at 5 years. Bloods, I usually time them prior to the CT scan, as renal function is also required before they'll give the contrast, so that works well. By routine, I'll do the full blood count and renal functions. Other bloods are added in as per need. Urethral surveillance, in my protocol, I usually use the flexible urethroscopy on a yearly basis. However, it has been seen people have used the cytology, but I have not found any benefit in the cytology. And you usually stop this urethral surveillance after 5 years in an ileal conduit. However, those who have an orthotopic, they can continue for next 5 years. In the community, district nurses support is a very important for the patient, because most of the patients' worry is about the stoma management issues. And these factors are usually dealt with the district nurses, and they have a direct contact with the urology specialist nurses. And general factors which can be dealt in liaison with the GP. So that support is available in the community. So for these small problems, they don't need to come to the hospital. Role of a urology specialist nurse, they all have our contact number. They give their specialist advice on the stoma related issues. If they are getting recurrent infection and other symptoms, they escalate these problems, and then we involve, then as a consultant level, we involve, and then we get the required investigation. And secondly, the consultant review. If there is a need based on the symptoms or recurrence, then the patient comes to the hospital. And now we have changed, because of this video system is available, so we changed to the video follow-up, and then if necessary, then they come to the clinic. Lastly, so I think that was but as a North Cancer Alliance, what we have looked at it, because in the map, you will see around this area, this is even the larger than our own area, where there are 3 NHS boards which are mainly involved, and 2 of the boards are doing the major cystectomies, and their area is quite large and population is only 1.4. So we have to devise mechanism where patients' journeys should be restricted and get the adequate follow-up. So this is on the screen, you can see this is one of the, it's in the draft format at the moment, but this is one of the proposed things after radical surgery, which is more or less same why I follow. So that's the conclusion of my talk, and I'll just stop here. I hope I have not taken much time.
Absolutely not. Thank you very much, Mustafa. I mean, I always find these very useful, these follow-up, especially the community follow-up models that we follow. So we have finished all the lectures. Thank you very much. And I think if quite a few of us still willing to stay, and we could have some question and answers, if it's not getting too late. We are already overrun by half an hour for lectures regarding oncology and then urinary diversions. If anyone has any comments to make. Right, in that
is Professor Anwar Hussain still here?
Yes. Just need to unmute yourself.
Yes, Shabi, I'm still there, yeah.
I'm sorry, I didn't want to do waste the time before. So one quick question about this is very interesting, the new adjuvant combination which you have introduced.
Yeah.
One quick thing, I did a lot of work about neoadjuvant chemotherapy once upon a time as a trainee, even before becoming a trainee. And at that time, we were comparing GemCis versus the old MVAC regime. But what I found were quite startling differences in the outcomes of neoadjuvant between just muscle invasive disease versus muscle invasive with CIS. So in your cohort, did the CIS factor mattered in the outcomes?
It's a very good question, Shabi. I think CIS numbers are usually quite small. So in our setting in neoadjuvant trials, what we usually do is that we allow patients with CIS as well. We do look at that as cohort, but I think the data that I showed was on 120 patient randomized trial. In a larger cohort, we always look at the outcome on CIS. What we know is that they are a bit more radiation resistance we find in patients with CIS, and those are the patients we quite often move towards cystectomy, guide them towards cystectomy as well. But in terms of neoadjuvant chemotherapy, we do see patient responding to that. So even if you have CIS left, what I showed one of the slides which showed if you get PT0 or PT1 disease, especially if it's a PT less than 1, it could be PTO, PT, PTA, even with CIS, these patients do benefit from neoadjuvant chemotherapy. So anything that leads to downgrading of the tumor from muscle invasive to non-muscle invasive, that has a good impact on overall outcome. We want to basically look at that as a surrogate endpoint as well. But I think you make a very important point here that patients with CIS may be a little bit different in terms of outcome. We see it more with radiation than with chemotherapy.
Thank you very much. Rehan Khan, you have a question for Professor Hamad Athar, please.
Yes, thank you to all the presenters. Excellent talks. Thoroughly enjoyed both programs, Zishan. So congratulations to all the organizers and all the presenters on bladder cancer. My question to Professor Hamad Athar, I'm a urologist based in Glasgow, and I do cystectomies and neobladders. And I think the dynamics we have for patient uptake for a neobladder as compared to an isle conduit probably are different from as compared to Pakistan. And I think you have alluded to the fact that the religious aspect of urine touching their clothes or their skin and their ability to say their prayers probably plays a big part. But I mean, what's your experience of, if you offer it to say 10 patients, a neobladder, and there are indications to do it, I mean, how many patients take up the opportunity of neobladder or orthotopic neobladders, or continent urine diversion? So any experience on that? Any comments on that?
Right. Thank you, Rehan, for your question. It is an important area. I mean, general belief is that patients who are willing to undergo cystectomy would refuse the procedure once you start explaining the urinary diversion. Vast majority would be very keen to have an orthotopic neobladder. But once I have started a discussion, and particularly realizing that the patient may have difficulty in follow-up, and Mustafa has gone into the details of describing, and I have the pleasure of working with the student and learn my orthotopic bladder from him, and he's extremely religious about the follow-up. So when I start explaining to them that the technical problems are there are issues with redo at times, ureteroileal anastomotic strictures, etc. They would have difficulty in accepting, but ultimately majority who are not suitable for orthotopic bladder would accept urinary diversion if it comes to that, because every patient has to agree to both types of diversion before we take them to the OR. Personal experience is that once the patient is convinced about the disease and its treatment, very few have refused procedure only because of diversion. So it's a matter of how you explain. I have made a little contact group in which patients who have had the previous surgeries, like ileal conduit or orthotopic bladder, would talk, these patients would talk to them. And that's the best way of communication, because you may be at times not able to communicate proper. Unfortunately, the nursing support which is available to you guys in NHS is not available to us, that kind of nursing support. So the communication gap between patient and a urologist is there, and the other patients can help you. I hope I've addressed your query.
Yeah, no, thank you very much. I think you've made a brilliant point. I mean, that's something that I use as well. So I have a cohort of patients who have had various type of diversions, and they have consented for any future patients to be in touch with them. So they sometimes go out for a coffee together. I think the other thing I find useful in NHS is the patient's ability to obviously see the stoma team in advance, and they spend a lot of time in our setup with them, you know, multiple visits. They go home with trial devices. So I think that helps allay a lot of fears, certainly in NHS patients. But I think you're following more or less similar program in Aachen, which is quite good to hear. Thank you very much.
Thanks a lot. Thanks a lot.
Ishan, can I ask a question?
Yeah, please.
Yeah, can I ask all of us who are congregated in this program remotely to join me in thanking Zishan for putting up an exceptionally good webinar and program. And having said that, can I ask, is Shamim around, or is any of the other cystectomists around?
Yeah, I am here.
I think, yeah. What is your standard of lymphadenectomy in cystectomy? Are you all doing level 2, or some of you go to level 3? I think particularly a colleague from Karachi, who I have huge admiration after listening to him, what he's achieving, despite all the obstacles and given the situation in Pakistan, patients agreeing to it. I think, having spent time in with Studio, you probably are doing level 3 or just level 2 lymphadenectomies.
Extended lymphadenectomy.
Level 3? Level 3 or level 2?
Level 2.
Level 2, okay. Yeah. Mm-hmm.
Great. Thank you.
Shamim?
Yeah.
Let's make a few points about, we had a discussion about diversions. Remember one thing, never force on patients that just because younger or healthier. It's about their psychology.
Yeah.
Some patients who come to the clinic and actually they don't focus on the cancer, but they are more focused on the type of diversion they are going to have because they have been brainwashed by somebody who's referring you. You must make sure that the patient understands what they are going through. Ahmad has done a brilliant presentation, but my concern about Pakistan is that, we are a very poor country. The people who are coming to Aga Khan may not be necessarily the representative patient for the rest of the community. So I'm not sure that what is the availability of the stoma bags, for example, in Pakistan, how expensive they are, how many people can afford it, and therefore I think we should try to give it type of urinary diversion. I do go to Pakistan. I've done a few cystectomies on patients and try to do various types of urinary diversion where they don't need stoma. But I did a cystectomy last visit, and there's a guy, the spina bifida, 18-year-old, and had to do an ileal conduit because the renal function is going off and all that. And actually, I'm going to sending stoma bags from here because the stoma bags which are available locally, but not good enough, not sticking well. And therefore, these are the things which personally, I'm sitting in Aga Khan, for example, and you are doing quite a large, good volume. I think you need to, I don't know, somehow make a group or something who can help each other so that they can provide these external appliances, because not all patients are suitable for continent diversion. Their renal function may not be good or some other reason. But what I've personally learned from continent diversion, I have a lady who was from Belgium. She came here, I did an orthotopic bladder on her, And twice I had to admit her with severe acidosis because she was not compliant in self-catheterization. So you have to, one size doesn't fit all. You have to choose your patient correctly and do a good operation and then good follow-up if you want to have good outcomes.
Shamim, I would agree with you 100%. And I can tell you from my experience working in the third world on the postnatal fistulas and those circumferential fistulas where nothing else but diversion. And I find the interposition, as Professor Stanzo alluded to, and also the MINDS too, so long as they got a reasonable rectal capacity and control, they are very easy to manage remotely, and even to prevent acidosis, the ordinary soda bicarbonate and local sort of follow-up is a lot easier than having to worry about the surface stomas.
I agree with you, Asher, but the problem with a fistula patient, they may have not a very good anal sphincter. So that is something that assessment has to be very meticulous so that they're not both continent of urine and feces. And
no, these, you're right, but these are not where there's a complete, this is the vaginal circumferential with the preservation of the anus. It's not where there's not a third-degree tear. It's just the vaginal wall circumference. So you're right. I think they have to pass the anal continence test first. They are able to retain 300 plus of anima.
I'll tell you, I went to Ethiopia a few times, and there are some patients who had very bad fistulae, and they only needed urinary diversion, and they made a hostel for these people because they couldn't go back to the community with the issues with the bag. So I think the two gynecologists who established this center, they have been very kind. They established a hostel for them, and that is where they live. So in our country, I think the problems are not very dissimilar, particularly in a poor population where I think they can't afford to eat twice a day. So what about the bags and other things? Therefore, we should come up with some improvisation where they can have a safe diversion. And as you mentioned, maybe soda bicarb is not a very expensive medicine, but their compliance is essential because otherwise they will become acidotic and some of them will die of acidosis. And follow-up is a problem.
Zishan, may I have some comment and questions? Hello?
Yes, please. Please.
Yeah. No, first of all, really grateful you have organized a fantastic webinar and very distinguished panelists and speakers. Enjoyed talk from all corners. One sort of suggestion to Hamad that if you can't have a trained clinical nurse specialist for the cystectomy and other urological procedures, if you want, you can have some patient educators. And my experience working in King Faisal Hospital in Riyadh was really, I learned a lot there that patient educators are sometimes very good. They can spend a lot of time with the patient, explain them different diversion options, and really motivate them as well. So there's a lot more chance that people will opt for a continent diversion or orthotopic bladder than otherwise. And we did almost 70 to 80% of patients we did in Riyadh were continent diversions. Luckily, we had some very renowned Swedish professors which I worked with, and they were original part of the team with Professor Koch. So it all depends, how do you educate the patient? And I've seen here as well in UK with my practice that making people agree to do orthotopic bladder is much more harder job than I experienced in Riyadh, which is so-called not one of the developed countries. So that's the point. You can take some simple graduates, science graduates, and in a year or two, they will be up and running and they will help you a lot with all these complicated procedures, and they can spend time with patient with all the info and others. Secondly, I would have liked to ask Sheila, but I think she might have left the webinar. But if she is there, I think the very important aspect is not only the preoperative, but perioperative and postoperative care, particularly what sort of anesthetic is used, what combination is used, postoperative pain management. And with the enhanced recovery program, what I learned in Derby, a remarkable change, with giving just a half mil of diamorph, spinal diamorph followed by, one of my anesthetic colleagues, not all of them, is very keen on using IV lignocaine. Then there is a tranexamic acid, use of that during the surgery. And post-op, as soon as you finish the procedure, tap blocks, they've been proved excellent. The patient is literally pain-free till at least, 18 hours or something before they require any analgesia. So I think these are very important aspects of patient recovery as well. Similarly, they have already reduced the risk of ILS and other things. So I think if Sheila is there, she could allude to it. Otherwise, maybe Shamim Khan can say something, what they practice from an aesthetic point of view. What is their protocol?
I think Sheila is not with us. I think she has just left for the day.
Well, any other colleagues who are on the forum, would like to say. But I found it a very good combination of.
Yeah, I would agree, Amjad. I would fully agree with you. I would fully agree with you. We have a similar practice, and I think certainly the IV lignocaine and we use the pain busters, which are similar to tap block. And patients can use it, and they're certainly in open, but not in those who are doing the robotic, which is, I think, game, and I think that's it.
I think your voice is breaking up, Asher. Cannot really.
Oh, sorry. Yeah. Sorry, what I'm saying that I fully agree with
yes.
Amjad, and we have a similar practice. But what I was saying that we should probably be all moving to robotics, hoping that Shamim will persuade them to lower their price, and it'll be much more common tool to use. And I think that is the future, without any doubt and without any random prospective trials. There's no doubt in my mind, being a non.
I think we lost him again.
I think you end up muting yourself, Asher.
Oh, sorry. No. What I was agreeing, and I was saying robotic.
We got that bit. Yeah, that's great. Yeah.
Yeah. Robotic is the future, and I hope Shamim is able to, with his colleague, to persuade them to reduce the price. So for people, I'm actually towards the end of my career. The people who will be coming on, they all be having access to that. It's just a new tool. It's not a toy. It's a tool, and it has its benefits, even in the absence of. Personally, I don't believe you need a randomized controlled trial. There's no doubt about it.
Thank you.
Well, I'm just answering your question. Actually, if in robotics, we just give them one short spinal, and some of them, may get this local anesthetic block if they are having open operations. But for robotic, to be honest with you, just minor, local infiltration at the end and bit of, PCA occasionally they need, but for females particularly, they don't need anything apart from stoma site and for example, what do you call it, few where you have the very small incision, they don't need much analgesia after the operations.
Ishan, can I ask a question to Professor Hussain, please?
Yes, please. I think some people may need to leave. I'm just conscious that I personally have no problem. Brian, are you okay with time and all? Yeah.
I'm for a little while, yeah, but I've got two children in the background that are getting restless.
That's fine, okay. Mazhar, if you could very quickly.
Yeah, thanks very much for an amazing talk, all of you guys. It was very interactive sessions.
That's great.
So far. Professor Anwar, just wanted to ask you the role of immunotherapy in post-cystectomy setting as an adjuvant. Is there any role of immunotherapy?
Very, very topical question, Mazhar. It's literally just came out this week. As you might have seen, there's a paper that's out looking at nivolumab, which has shown as a progression-free survival benefit. Previously, there was an atezolizumab trial at ASCO this year, and that was a negative trial. It did not show improvement in PFS or OS. But what is interesting is that nivolumab in this setting has shown improvement in progression-free survival. And that was in patients who were either post-neoadjuvant chemotherapy, had at least PT2 disease, or had no neoadjuvant chemotherapy and had at least PT3 disease at cystectomy. So it's an interesting step forward, but again, you would like to see it improvement in overall survival, because we know that these drugs are now available in second line. Based on the Javelin 100 data, it will start to become maintenance treatment. And I think we are bringing it forward. And as I mentioned in my talk, that there's a new adjuvant trial going on looking at gemcitabine plus cisplatin plus durvalumab plus gemcitabine plus cisplatinum in a randomized trial, which is the Niagara study.
Thank you very much. So, I mean, to be honest, just an amazing session going on, and I've never really enjoyed that much, despite that bladder cancer is not my subject directly. So we would just have to conclude, and I would just request first Mr. Brian Chaplin just to make some concluding remarks, and then Professor Mumtaz Ahmed, as president of PAUS, what he thought about today's session. So Brian, please.
Well, first of all, I would like to thank you for inviting me. It's been a great honor for both of the sessions, the non-muscle invasive and this one. I have learned an awful lot. I think if I was just to take two take-home messages, one is the importance of collaboration with our colleagues, particularly the anaesthetists and again our medical and clinical oncologists. That can't be emphasised enough, the collaboration with those two groups of patients in the care of those two groups of doctors with the care of our patients. The other thing is the careful selection of patients, and third is the robots march on and is here not only now in the here and now, but here for the future and here to stay until something else overtakes it. So once again, I've excellent sessions today, and thank you once more for inviting me. Okay.
Thank you very much, Brian. It's always great to have you. Thank you so much for your time. Professor Mumtaz, please, thank you very much for your continued support for this. If you would like to please say a few words.
Thank you, Zishan. I would like to say thanks to every participants, for all the faculty and moderators for making this webinar a success. Now, the major problem, major challenge in our country for the management of carcinoma bladder, I would say still is the affordability of the patients. Unless we have free treatment in public sector hospital, or in terms of radical cystectomy and the diversion, otherwise this is not going to be benefited for our public who cannot afford this treatment in the private hospitals. Thank you very much.
Thank you very much, Professor Mumtaz. And before I conclude, I would like to thank all the panelists, speakers, and participants, and especially thanking a few colleagues behind the scene, Mazhar, Shabi, Sarfraz, and Mr. Asim Chaudhry for helping out with the program and everything, which has made this so much successful. And we will clearly discuss about future topics to keep this going. And while most of our senior colleagues are here, I just wanted to take a bit of advice that from a timing point of view, shall we reduce the number of talks and keep more time for discussion? Because these discussions are so useful, and exactly the idea behind all this. Professor Shamim, what would you say for that?
I think I would agree with you that you should have more time for discussion, and some people may bring cases they want to discuss, get an opinion, so that they get into a habit of collaborating with other people.
Great.
I think there is a lot to cover, but you have to just pick the area which is the crucial thing, which is the new things, and what are the difficult questions they face in their daily practice. And sadly, we have not got into the habit of getting, for example, focusing cases in major centers. We are far away, but I think things will happen, and it's a question of educating and getting the people take on board these ideas. People get fatigued, and I think that Sunday would be a better day, in my opinion, rather than the Saturday, because a lot of people in Pakistan work on Saturdays. So Sunday, I personally think would be a better option for more attendance if you want to disseminate.
That's great. Fine. Thank you very much.
One last comment, Zishan, and if panelists and participants agreed that in future, can we consider doing a sort of a MDT sort of a session so that tricky cases, difficult cases can be brought here, because I appreciate that MDT facilities might not be as well developed in Pakistan, and colleagues from both sides would benefit from discussions in that regard, and maybe even able to refer patients from one center to the other. So if that could be considered in due course.
That's fantastic, Shabi. I think this idea has been on board as well. And we have a session on 20th of October, but that's with African organization, mostly for residents. But I'll send you everybody the link, and everyone is free to join, and we can use it as a tester and then plan our own with PAUS. So I'll definitely share the link for that. That's mostly for residents.
Thank you very much.
Thank you very much all. Thanks a lot. Mr. Mekar, you.
Yeah, can I just thank you about this meeting? It's a fantastic way to spend the Saturday morning, to be honest. Just as an observation for future meetings, when we're dealing with complex issues like muscle-invasive bladder cancer, its optimum treatment, and so on and so forth, the adversarial style of the talks, which all were excellent talks, doesn't do the controversy justice. So if you get somebody who's very in favor of robot-assisted surgery, and somebody who is very in favor of open surgery, and get them to have their opposing views heard together, or to have a duel together, that would be more informative. If you get somebody who is very in favor of neoadjuvant chemo as opposed to very in favor of adjuvant chemo, and get them to have a duel together, that I think does the controversial issues a little bit more justice and becomes more informative.
Definitely. Thanks, Mr. Mekar. So that's another, like, a debate style. Yeah. So I think these are things, ideas evolving, just to probably reduce the number of topics and then have more discussion and debate sessions. Thank you very much for your input. And I'm really glad you were here and enjoyed it. Great. So thank you very much, everyone. We can conclude now until we meet next, hopefully in a few weeks' time, and have a nice rest of the weekend. Bye.